السلام عليكم ورحمة الله وبركاته. Is my voice clear?
عليكم السلام ورحمة الله وبركاته. Clear, doctor.
عليكم السلام ورحمة الله وبركاته. واضح يا دكتور.
So I will start immediately, inshallah. This is the first session in the BIS module for preparation for European Board examination and subspecialty examination in endocrinology and diabetes and metabolism. And actually, this is one of the most important sessions in diabetes because a lot of questions in the final exam and also in clinical practice. This session is very important. So as I mentioned in every time, this is a diabetes module in my course, and actually the thyroid sessions already most of them are finished, and for who subscribed in my course, this is actually the website, the YouTube channel. In this YouTube channel, all of the previous recorded sessions are presented or listed in the playlist. So not in this home page, but in the playlist. So you need to go to the playlist. And actually, I will put all of the recorded sessions in this playlist. For example, for all of the previous thyroid sessions online, recent sessions presented here in the thyroid disorders, and this contains 16 sessions, and actually all sessions are presented from the first one. This is the first one since a few months, and you can follow this is from the bottom of the list to the upward, and this is the last sessions I upload it since the previous Friday. And inshallah, I will continue solving thyroid questions and the thyroid previous exam, inshallah, later on. So this is the playlist. You need to go to this playlist to review all of the previous recorded sessions. Also, inshallah, this will be put in separate playlist for diabetes sessions, inshallah. And also, I already upload and send the link of the previous recorded sessions. This is the thyroid sessions. I already sent the link of it, and also I upload the PDF files of the thyroid sessions, updated questions bank, study BRN on examination, exam lab, and so on. And also I uploaded PDF files of my notes for the thyroid, especially day 1 and day 2 and day 3. And also I upload the guideline PDF files of my sessions and the previous session. So inshallah, in diabetes, the same material will be uploaded for diabetes sessions, and I insist in every sessions to say that these tools, files, and videos are not for redistribution. This material for your personal use only. And also, as I mentioned in every time, this is not academic presentations. I want to be interactive presentation. So any question at any time, please let me know, stop me and ask any question or add any comment at any time. So this, I want to be interactive sessions. And actually, diabetes is very important in the final exam. Final exam consists from 200 questions. Diabetes questions is about 68. So it represents about 34% of the final exam. And actually, diabetes contains diagnosis and general management, diabetes emergency, and complications of diabetes. The most difficult part is the first part, diagnosis and general management of diabetes. Most of us may answer those questions incorrectly because a lot of factors. What you practice is actually is different than the exam scenarios. So you need to prepare yourself from today to answer the questions as they require. So diabetes is a very important module because it represents more than 30% of the final exam. So this is my agenda for diabetes module, and actually during preparation of this material I may change some of these topics to be put in another day, so it is updated curriculum. So inshallah today I will cover diagnosis of diabetes, classification, and actually classification and diagnosis is very important because in each exam they will ask a question about the diagnosis. And also genetics of type 1 and type 2 is very important, and each exam you will face a question about genetics of type 1, especially type 1. For example, if the father is type 1 diabetes, what is the risk for his daughter to be type 1? And also one of the most important topic today, inshallah, MODY diabetes, maturity onset diabetes of the young, is very important topic. Classification, types of MODY, and how to diagnose each one, how to manage. It's very important topic in the exam, and actually in the exam they will put 2 to 3 questions about the MODY types and the classification and management. Also neonatal diabetes, which is diabetes diagnosed before the age of 6 months of age. This is actually not very important, but at least you need to know what is a neonatal diabetes, which is one of the monogenic diabetes. Monogenic diabetes is MODY diabetes and neonatal diabetes. So it is very important to at least to know what is a neonatal diabetes and types of neonatal diabetes. Another important type of diabetes which is very rare is mitochondrial diabetes, and inshallah I will cover it. Also some of other rare disorders of severe insulin resistance I will cover it, and also how to assess a newly diagnosed patient with diabetes, and also I will cover some of diagnostic tools which may be available online, and also lastly I will end by LADA, which is latent autoimmune diabetes of adults, and ketone-prone diabetes, and some of gray cases or gray types of diabetes. So I would like to start by this paragraph written by Elliot Joslin. Elliot Joslin, one of the pioneers in the management and educational diabetes, and actually he's a US physician on the role of the self-management of education in diabetes. He said that the diabetic who knows the most lives the longest. So start from today, education is very important in management of any patient of your in any patient with diabetes. So try to educate your patient about how to self-management of diabetes, which is very important. And actually in Egypt I am so proud that we have a lot of Facebook sites, and actually أطفالنا والسكر, I would mention that أطفالنا والسكر is one of the top of Facebook pages that deal with type 1 diabetes and carb count, and how to manage diabetes complications, either acute or chronic diabetes complications. So I would like to thank Shayma Ladawi, one of the pioneers in management of educational topic, وهي طبعا مثقف سكري شهير. So I will start my sessions today by this question from one of the best, most important sources for preparation for SCE and European Board, a toolbook, which is best of 5 MCQs for the endocrinology and diabetes. And actually this question asks about prevalence of diabetes, projected prevalence of diabetes in 2030. He asked about what will be the projected prevalence of diabetes in 2030 based on estimated by IDF. Is it will be 50 million or 60 million or 578 million or 1 billion or 1.5 billion. So what is your answer?
D.
D.
What?
D.
C.
D or C?
C.
Yes, Dr. Ashraf, the correct answer, and Dr. Najah, is C. And actually, I would like to mention that the prevalence numbers is actually dynamic. So in our Oxford handbook, they mentioned that, of course, as all of us know, that diabetes is mainly a defect in insulin secretion and or insulin action. And they mentioned that about the prevalence of diabetes in the UK is 6%. And they mentioned that today, worldwide diagnosed diabetes is about 463 million adults. And this number predicted to be 578 million by 2030. And actually, this is the number mentioned in IDF Diabetes Atlas, which is published 2019. They mentioned that this is the number mentioned in the ninth edition of IDF Diabetes Atlas, but this atlas is updated recently in the previous year, and they mentioned that in 2030, the predicted number of diabetes will be 643 millions. So don't forget that the prevalence numbers may be changed according to the last updated recommendation or guidelines. So this is the most recent numbers mention that prevalence of diabetes in 2030 will be 643 millions. And actually in the next edition of the IDF Atlas, I think this number will be changed because the screening and the diagnosis will be changed according to the updated numbers. So don't forget this. And actually, this is another question from the Atul book. He mentions that this is a 53-year-old woman presented with symptoms of increased thirst, weight loss, and increased frequency of passing urine. There is some of background medical history of bronchial asthma, and don't forget that bronchial asthma usually managed by inhaled corticosteroid, which usually is not cause steroid-induced diabetes because it just acts as a local medication. But in very rare conditions, it may induce diabetes. But usually, steroid to induce diabetes usually need to be taken by parenteral or oral route, for which she occasionally used a salbutamol, which is a beta-2 agonist. On examination, the body mass index 29 kilogram per cubic meter. General physical examination and systemic examination was unremarkable except central adiposity. The fasting and the random blood glucose were the fasting 6.5 millimole per liter and the random 9.2 millimole per liter, respectively. And ask about the cutoff biochemical cutoffs are diagnostic for diabetes based on WHO criteria. And actually here I would like to mention that units for random and fasting blood sugar, we should remember that we have two units, milligram per deciliter and millimole per liter. And for most of European countries or all of European countries, they use millimole per liter. And this is a WHO criteria. So they ask about what is the biochemical cutoff diagnosis for diabetes. 1 hour plasma glucose more equal and or more than 11.1 on oral glucose tolerance test. Fasting blood sugar more than 6. Fasting glucose more than 7. Random blood glucose more than 8.5. Random in asymptomatic patient. Don't forget that the patient is symptomatic or asymptomatic. Here in point B, fasting blood glucose more than 6 with osmotic symptom, and C, fasting blood glucose more than 7 in asymptomatic patient. The random blood glucose more than 8.5 in asymptomatic patient, or random blood glucose more than 11.1 millimole per liter with osmotic symptom. What is the answer? So actually, we need to do to know that the difference between milligram per deciliter, as mentioned by Dr. Najah. Dr. Najah mentioned that C is the correct one, but actually this is
E is the correct one. E is the correct one.
more than
E is the
7,
correct
which
one.
is equal to 126, but they mentioned that in asymptomatic patient. One reading of fasting blood sugar in asymptomatic patient is not diagnostic for diabetes. We need to memorize this is because this is a very important. Yes, what is the answer?
Correct. E is the correct answer.
E. So I am with you that random blood sugar more than 11.1, which is equivalent to 200 milligram per deciliter, plus symptoms. One reading of random blood sugar plus symptoms may diagnose diabetes. But fasting blood sugar, even if more than 7 millimole per liter in asymptomatic patient, is not sufficient. So we need to remember the diagnostic criteria for diabetes actually. And I would like to mention that 1 hour plasma glucose is not a diagnostic criteria in any recommendation. Either American recommendation or British recommendation or WHO recommendation or IDF recommendation not depend upon 1 hour plasma glucose on oral glucose tolerance test. So oral glucose tolerance test, we need just fasting blood sugar and 2 hour post oral glucose tolerance test. 1 hour is not a diagnostic criteria. 1 hour can be a diagnostic criteria only in gestational diabetes mellitus. If we need to diagnose diabetes during pregnancy, 1 hour plasma glucose is one of the criteria for diagnosis of gestational diabetes. But actually, this is for American recommendation only. A NICE recommendation did not depend upon 1 hour plasma glucose even during the pregnancy. So this criteria is very important. So the right answer is random blood glucose more or equal to 11.1, which is equivalent to 200 milligram per deciliter with osmotic symptom can be is a cutoff biochemical diagnosis for diabetes. Another question from a British Medical Journal examination. This is the updated version of on examination. You are asked to comment on the result of oral glucose tolerance test. This is a 45-year-old obese and has a strong family history of diabetes, so has been screened for the condition using oral glucose tolerance test. And don't forget that for diagnosis of diabetes, oral glucose tolerance test must be 75 gram oral glucose, not 100. 100 gram oral glucose is only used during the pregnancy, not for non-pregnant population. So the oral glucose tolerance test for non-pregnant population must be 75 gram oral glucose. During the pregnancy, we have two protocols. One of them 75 gram oral glucose and another one 100 gram oral glucose according to the recommendation. The result given to you are as follows. The fasting plasma glucose 5.9. Don't forget that this is a millimole per liter. Plasma glucose 1 hour post glucose load 10.2 millimole. Plasma glucose 2 hour post oral glucose tolerance test 7.6 millimole per liter. So ask about what does this result indicate? Diabetes or impaired fasting glucose or combined impaired fasting and impaired glucose tolerance test or impaired glucose tolerance test or normal result?
Normal results.
Excuse me, doctor.
Yes.
Impaired glucose, impaired fasting glucose, the same pre-diabetic patient?
What about impaired fasting? Impaired fasting, this is a pre-diabetic. Yes. And also impaired glucose tolerance test is a pre-diabetic, but this is American terms, but in the British they mention that it is impaired fasting or impaired glucose, not pre-diabetic.
Okay, question, answer number 2.
Impaired fasting.
Yes, because
normal
pre-diabetic from 100 to 125 in America.
So actually I
This
see a lot of
patient has
answers,
type
but the correct answer according to the according to what is the normal reference range for fasting. And actually we need to know that the fasting plasma glucose is the cutoff points of fasting is different from WHO and from the American recommendation.
Okay.
And actually in the own exam they answer the right answer is impaired fasting. Why they answer it as impaired fasting, and this actually is the American recommendation? Because in American recommendation the lower limit of fasting plasma glucose, their normal fasting plasma glucose is less than 5.6, which is equivalent to 100 milligram per deciliter.
99, yes.
But in WHO they recommend that in normal fasting is less than 6.1 millimole per liter, which is equivalent to 110 millimole per liter. So according to the American recommendation, this is a normal OGTT. Of course, in 1 hour is not, we should omit 1 hour value. 1 hour value, which is 10.2, we should omit it, because in oral glucose tolerance test, 1 hour value has no value. We just depend upon the fasting and 2 hour. The fasting, which is 5.9, according to the American recommendation, this is a pre-diabetic, because they mention that a pre-diabetic between 5.6 to 7 fasting. So in normal fasting will be less than 5.6 in American and IDF recommendation, but according to the WHO, which is the correct answer for the exam, the fasting blood sugar, the normal fasting blood sugar is less than 6.1. And actually I bought the explanation from the exam lab, and they mentioned that this is according to the American Diabetes Association and IDF. And actually I bought another table from the Oxford book of endocrinology and diabetes. They mentioned that this, as I mentioned, the fasting plasma glucose according to the WHO for diagnosis for diabetes if more than 7, but impaired fasting if fasting plasma glucose between 6.1 and 6.9. This is the WHO recommendation, and this is the latest recommendation published by WHO in 206. And actually this number is not changed up till now. But for the American, they diagnose pre-diabetes if fasting plasma glucose from 5.6 to 6.9. So don't forget that the American Diabetes Association diagnostic cutoff points for pre-diabetes is different than WHO. And also I would like to mention this this image, and this actually from the Oxford textbook of the medicine. They mentioned that the fasting blood glucose is less than 5.6. This is the American, and the cutoff point for diagnosis of diabetes for fasting blood sugar if more than 7, and impaired fasting between 5.6 to 7. But actually I put this blue number 6.1 because this is a diagnostic according to the WHO. So don't forget that numbers. And actually I know that most of us may conflict with this a lot of numbers, but during your practice
I will answer according
memorize
to
this
WHO
numbers
or American Association.
What?
In exam, I will answer according to WHO or American
WHO, and nice recommendation. WHO.
But this patient, but this question answered according to American.
Yes, I am with you. So in the exam, this is a normal result. Actually, this is a normal result. not impaired fasting plasma glucose. And actually on exam, they mentioned some of the question according to the American recommendation. But during explanation, they mentioned that this is according to the American Diabetes Association and IDF recommendation, not WHO recommendation. So I insist to put the Oxford textbook of endocrinology and diabetes table, and also the Oxford textbook of medicine, and actually both the American recommendation and in their head of this paragraph, they mentioned that this is American Diabetes Association recommendation. So I will cover this in more details later on. But what I would like to say, numbers is very important, and don't conflict yourself by the number. And actually in the American recent American recommendation and guidelines, they put units by milligram per deciliter, and also they put by millimole per liter. So don't conflict yourself in how to convert this number. What? In the latest one, 2022.
اضربها في 18 ملي جرام
according to
multiply by
exam, this is
18.
normal result.
Yes,
or,
yes, how to convert, yes. I would cover how to convert this number, this interval later on. Okay, Dr. Ashraf. Yes, I will cover this. So, a diagnosis of diabetes should be made biochemical diagnosis. Even if the patient is presented by typical manifestation of diabetes, polyuria, polydipsia, weight loss, and so on, a biochemical diagnosis before starting of the treatment. And biochemical diagnosis based on fasting, postprandial, which is 2-hour post-oral glucose tolerance test made by 75 gram anhydrous glucose. Don't forget 2-hour postprandial, not 2-hour after different meal. It is 2-hour post-oral glucose tolerance test. And also since 2010, hemoglobin A1C is put as a diagnostic marker for diabetes. And also there is impaired glucose tolerance test. Impaired glucose tolerance test means what? Impaired 2-hour post-oral glucose tolerance test. And of course, hemoglobin A1C is a cutoff point which diagnosis diabetes will be more than 6.5% or more than 48 millimole per mole. So we have two units to be used for fasting and random blood glucose: millimole per liter and milligram per deciliter. And another unit for hemoglobin A1C, which is percent, and another one millimole per mole. And how to convert this is very important. Actually, in some countries like Egypt, for example, because in Egypt we use usually hemoglobin A1C percent, and we usually use random blood sugar milligram per deciliter. But in the exam, hemoglobin A1C unit will be millimole per mole, and random blood sugar and fasting blood sugar will be millimole per liter. Diagnosis of diabetes is confirmed in any person with typical hyperglycemia, symptomatic polyuria, polydipsia, and weight loss, with random or postprandial blood glucose more than 11.1 millimole, which is equivalent to 200 milligram per deciliter, or fasting plasma glucose more than 7 millimole per liter, which is equivalent to 126, more or equal to. And actually, as I mentioned, units used for random and post glucose and hemoglobin A1C, we need to know how to convert these units. And actually, for random blood glucose or fasting blood glucose is simple. To convert from millimole to milligram per deciliter, just multiply by 18. So, for example, 10 millimole per liter fasting blood sugar is equivalent to 180, because we just multiply by 18 number. How to convert from milligram per deciliter to millimole per liter? Just divide by 18. Okay, so 180 milligram per deciliter random blood sugar is equivalent to 10 millimole per liter random blood sugar. So this is a simple how to convert from millimole per liter to milligram per deciliter, either fasting blood sugar, random blood sugar, 2-hour post-oral glucose tolerance test, or even 1 hour post-oral glucose tolerance test. This is a simple, just remember 18, multiply or divide by this number. How to convert hemoglobin A1C value from percent to millimole per mole or vice versa is very difficult, because it needs equation like this. Hemoglobin A1C by millimole per mole equivalent to hemoglobin A1C percent minus 2.14 multiplied by this number. But actually you didn't need to memorize this equation. There are a lot of tables like this, and they mention that this is the hemoglobin A1C percent and the equivalent hemoglobin A1C by millimole per mole. And actually, if you it is difficult, you have a online converter like this, and I will go to this online converter. This is the website for hemoglobin A1C unit converter. You need just to write hemoglobin A1C by percent, for example 7, and they will write the equivalent hemoglobin A1C by millimole per mole. If you, for example, write hemoglobin A1C, for example 5.6, it will be equivalent to 37.7 and so on. So 10 hemoglobin A1C is equivalent to 85.8 millimole per mole. So this is converter is important if you need to convert from percent to millimole per mole. So conversion of random and post-oral and random blood sugar and fasting blood sugar is so simple, but conversion from hemoglobin A1C percent to millimole per mole is more difficult and need a specific website like this. But actually in the exam and in the updated guidelines published by American Diabetes Association, they put both numbers. And actually, if you see the guideline published by the American, I will mention it, for example, in this one, they put hemoglobin A1C more than 6.5, and in Preset, they mention that the equivalent number by millimole per mole. And actually, nice, they write numbers like this. So don't conflict yourself by how convert from 1 to 1. I will cover this, Dr. Saadei. How far apart should the two reading of blood glucose be for asymptomatic patient? So this table is important because this is a diagnostic numbers for diabetes and according to the PREACH recommendation. In normal fasting blood glucose, and this is the same for WHO, this is the same numbers for WHO. Normal fasting is less than 6.1 millimole per liter, which is equivalent to 110. And actually, this is the main difference between PREACH recommendation and American recommendation. A 2-hour post-oral glucose tolerance test in normal value is less than 7.8, which is equivalent to 140 milligram per deciliter. A diagnostic criteria for diabetes, we diagnose diabetes if the fasting is more than 7, which is equivalent to 126, or 2-hour oral glucose tolerance test is more than 11.1, which is equivalent to 200. And this is the most number to memorize, 7 and 11.1. Impaired fasting, when we diagnose impaired fasting, if fasting blood sugar is less than 7, because if more than 7, this is a diabetes. And 2-hour oral glucose tolerance test is between 7.8, which is the normal 2-hour post-oral glucose tolerance test, and up to 11.1, which is a diagnostic cutoff point for diabetes. Impaired fasting, a 2-hour should be normal, but the fasting is elevated more than 6.1 and less than 7. And also hemoglobin A1C since 2010 is a diagnostic marker for diagnosis of diabetes. But actually for the bridge, they mentioned that the normal hemoglobin A1C is less than 42 millimole per mole, which is equivalent to 6. Don't forget that. Normal hemoglobin A1C according to the American recommendation is 5.7, not 6. So this is another difference between bridge and American recommendation in numbers. Normal hemoglobin A1C according to the NICE recommendation, hemoglobin A1C normally is less than 42, which is equivalent to 6. So impaired glucose tolerance test or pre-diabetes from 6 to 6.4. In American, impaired pre-diabetes regarding hemoglobin A1C is between 5.7 and 6.4%. But in the British, pre-diabetes hemoglobin A1C between 43 to 47 millimole, because 43 is equivalent to 6, 47 equivalent to 6.5. And diagnostic hemoglobin A1C for diabetes is more than 48, which is equivalent to 6.5, which is the same as American recommendation. So the main difference in this table from American and the British, the fasting blood sugar is different, and in normal hemoglobin A1C is different. Other values the same. As respect, the impaired fasting blood sugar, the normal lower limit of the normal up to 7 as the diagnostic cutoff point for diabetes. So this is a very important. And actually in the Oxford handbook, they mentioned that this number is American, in the American recommendation is 5.7. Yes, actually diagnostic cutoff points the same for pediatrics as adults. But hemoglobin A1C is not a very important criteria for diagnosing in pediatrics. The cutoff points, these cutoff points for fasting blood sugar and to oral glucose tolerance test for all general population, pediatrics and adults. So in a previous exam in 2021, they gave a scenario, a patient blood sugar, fasting blood sugar is 6.5 millimole per liter, and post oral glucose tolerance test 2 hour is 7.4, and ask about the diagnosis. And actually, as the fasting blood sugar is more than 6.1 and less than 7, and normal 2 hour post oral glucose tolerance test, so this is a impaired fasting blood sugar. Yes, impaired fasting. So I would like to mention this table, and actually this is the WHO recommendation published in 2020. The same diagnostic criteria for diagnosis of diabetes, but they mentioned that fasting can be venous or capillary. The 2 hour venous sample, the cutoff points for diagnosis of diabetes is 11.1, but a 2 hour post load capillary plasma value should be more than 12.2, which is equivalent to 220 milligram per deciliter. And actually, this is the first time I see this number. But actually, this is the WHO recommendation and IDF recommendation, the latest one. So don't surprise if you see a diagnostic value of 2 hour post oral glucose tolerance test in some presentation more than 12.2. This is for capillary plasma glucose.
Dr. Khalid, capillary plasma glucose
accurate enough as venous. All of the recommendation recommend venous blood sampling. So if you take a capillary blood sample only if a laboratory measurement is not available, If venous plasma is not available, you should use this cutoff point. Yes?
Okay, you are answered my question.
Okay. So I put this image because the routine recommendation, and actually I put the WHO diagnostic criteria to mention that in fasting plasma glucose, they mention that in normal fasting is less than 110 milligram per deciliter, which is equivalent to 6.1 millimole per liter. And put the updated diagnostic criteria for diagnosis of diabetes according to the WHO and IDF, and this is published in 2020. So this is the last recommendation. Other values the same as American. And I already put the latest American recommendation, and as I mentioned, this is criteria defining pre-diabetes or pre-diabetes. Fasting plasma glucose between 5.6 to 6.9 millimole per liter, or 2-hour post-oral glucose tolerance test. Oral glucose tolerance test should be 75 grams, between 7.8, which is equivalent to 140, to 11 millimole per liter, or 11.1, which is the diagnostic marker for the diabetes. And hemoglobin A1C 5.7 to 6.4, which is equivalent to 39 to 47. And don't forget that for all three tests, fasting, 2-hour post-oral glucose tolerance test, and hemoglobin A1C, the risk is continuous, extending below the lower limit of the range and becoming disproportionately greater at the higher end of the range. And don't forget that random blood glucose is not a criteria for diagnosis of prediabetes, because we have no lower limit of the random blood sugar. We have a diagnostic criteria by random blood sugar for diagnosis of diabetes, but we have not a criteria for random blood sugar for diagnosis of prediabetes. We just have a fasting blood sugar, 2-hour post-oral glucose tolerance test, hemoglobin A1C.
But السلام عليكم يا دكتور خالد.
وعليكم السلام ورحمة الله.
الاي دي اي كمان حاطه انه الراندوم بلاد شوجر ان patient symptomatized above 11.1 is a diagnostic criteria.
Yes, and I already put this table. This is the criteria for diagnosis of diabetes. They mentioned that. This is the American, and actually the same as your nice recommendation. Fasting blood sugar is more than 7, or 2-hour post-oral glucose tolerance test more than 11.1, or hemoglobin A1C more than 48 millimole per mole, or patient with classic symptoms hyperglycemia plus random blood sugar is more than 11.1. So in this patient, and they mention that every value of this should be repeated, except if a random blood sugar with a classical symptom. So we can diagnose type 2 diabetes or diabetes at general diabetes if we have a classical symptoms hyperglycemia with random blood sugar more than 200 milligram per deciliter or 11.1 millimole per liter by just one reading. But for other readings, we should have at least 2 abnormal tests result from the same sample or in 2 separate test samples. And the answer of a question of Dr. Saadiyya, the 2 samples can be taken at the same time or after each other without any interval. So we can do another test. If the patient already have fasting plasma glucose, we can have, and the patient is asymptomatic, in this situation, we can do hemoglobin A1C from the same sample. Or we can do 2-hour post-oral glucose tolerance test. Or to repeat the same test by another sample. In this situation, if the cutoff points are elevated, or this is sufficient for diagnosis of diabetes. And this is actually is very important in a clinical practice. But don't forget that if you have a type 1 diabetes with a high blood sugar with symptoms, don't repeat the sample, treat it by insulin. And don't wait a few days until the patient is presented by diabetic ketoacidosis. This is a critical condition. In this situation, you should manage your patient, not the numbers, because this is a critical situation for management of type 1 diabetes. And actually, this is a very important table. If you need a few slides from my presentation today, this is one of the most important slides in my presentation today. And actually, this is extracted from the Oxford textbook of endocrinology and diabetes, the latest edition, the third edition, which is published since we have it since a few days previously. They mentioned that diagnostic criteria for diabetes according to the WHO, which is the best. This is a recommendation by NICE. Fasting plasma glucose for diabetes more than 7, 2 hours more than 11.1. Hemoglobin A1C is more than 6.5, or which is equivalent to 48 millimole per mole, or random blood glucose in the presence of diabetes symptom. In the presence, random blood sugar in the presence of diabetes symptom. And also I mentioned that this table mentions that the criteria for diagnosis of diabetes according to the American Diabetes Association, the same numbers. The main difference between impaired glucose tolerance test, impaired fasting glucose, which is for WHO, and the pre-diabetes for American Diabetes Association. The main difference is normal fasting is less than 6.1 WHO, and the normal fasting for American Diabetes Association is 5.6. And another number is the same. Also, hemoglobin A1C is criteria for diagnosis of pre-diabetes in the American Diabetes Association, but not a criteria for diagnosis of impaired glucose tolerance test or impaired fasting. Because impaired fasting need a fasting plasma glucose, impaired glucose tolerance test need fasting and 2-hour post-oral glucose tolerance test. What if the two separate tests are not, Dr. Sadeh, this is a very important question. If the two separate tests are different, for example, if one is diagnostic for diabetes and another test is normal, in this situation, please don't diagnose diabetes by this single value. Wait for some days and repeat another test.
Doctor.
So we don't diagnose diabetes by one abnormal sample, except if for random with a classical symptoms of diabetes. And actually, as mentioned by Dr. Najah, I will treat it as a pre-diabetes or just wait and repeat the test. But in each situation like this, you should treat by lifestyle modification and metformin if not contraindicated, or the patient cannot tolerate it, because metformin is approved for pre-diabetes and approved for first line therapy for management of diabetes. So we will start metformin in this condition, but actually for diagnosis of diabetes we need two abnormal values. Yes, Dr. Ashraf.
Actually, Dr. Khaled, regarding this, the two tests are one with diabetes and another against diabetes. We have to repeat the test that is conflicting. That it means not the normal test.
Yes.
So another thing is if the patient is pre-diabetic, there is no treatment for pre-diabetes as the guidelines. So if you diagnose the patient as pre-diabetes, just keep it like this and follow up. No need for treatment.
No, and metformin is.
Metformin is approved as off label, and actually nowadays is approved by FDA. But actually, for the NICE recommendation up till now, pre-diabetes is just treated by lifestyle modification. So in clinical practice, in each situation like this, we should encourage our patient to lifestyle modification, exercise and diet, and to diagnose diabetes or pre-diabetes, we should repeat the test or conflicting tests as mentioned by Dr. Ashraf. Okay. So what is most important? Don't diagnose diabetes by single value, except if there is a classical thing. And this figure extracted from the latest edition of Oxford textbook. Actually, this is the Oxford textbook of medicine, not the Oxford textbook of endocrinology and diabetes. And this is the last edition. This is the 6th edition. And actually, they did not mention this value for fasting, 6.1. And they mentioned that this is a diagnostic threshold of diabetes according to the Diabetes Care, which is the official journal for American Diabetes Association. So I put this number here because this is the WHO number for fasting blood glucose, normal fasting blood glucose, and impaired fasting plasma glucose. And also this is recommended by the NICE. So the fasting plasma glucose is less than 6.1. This is a WHO recommendation. The cutoff point for diagnosis of diabetes 7, between 6.1 and 7. This is impaired fasting. 2-hour post-oral 75 anhydrous glucose, oral glucose tolerance test. The cutoff point in normal less than 7.8. And the diagnostic cutoff point for diabetes is 11.1. Between 7.8 and 11.1, this is impaired glucose tolerance test. And the random plasma glucose, there is no normal random plasma glucose. We just diagnose diabetes if random plasma glucose is more than 11.1, which is the same as 2-hour post-oral glucose tolerance test, but we diagnose by random if there is a classical symptom of diabetes. So this figure is very important to summarize all numbers for diagnosis of diabetes and impaired glucose and impaired fasting, and of course pre-diabetes. Another question from the toolbox: hemoglobin A1C is a commonly used tool that is employed for the diagnosis of diabetes, and actually this tool is just introduced for diagnosis since 2010. Also, it is a highly specific for diagnosis of diabetes. It is not particularly sensitive, because in some conditions hemoglobin A1C will be normal in a patient with newly onset diabetes, with a relatively more probability of obtaining a false negative test result. Which one of the following is appropriate indication for use of hemoglobin A1C for the diagnosis of diabetes? Appropriate indication for use of hemoglobin A1C for diagnosis: children, diabetes in adulthood, patient on steroid, patient with acute pancreatic damage, pregnancy. Which options from this is correct to be used hemoglobin A1C as a diagnostic criteria? And in another phrase, which condition hemoglobin A1C may give a false negative result?
False in children.
So children, hemoglobin A1C may give a false negative result, and also any pregnancy may give a false negative result. What about other options? We still have another options. Hemoglobin A1C will give false, may give. I would like to mention that may give a false negative result. So the patient hemoglobin A1C, for example, is 6, and the patient is diabetic. What about patient on steroid? Can we depend upon hemoglobin A1C for diagnosis if patient already on dexamethasone, mega dose of dexamethasone, and the patient presented by hemoglobin A1C is 6? Is this sufficient to exclude type 2 diabetes or not?
I think not.
Yes, I'm with you, because hemoglobin A1C just a mean of plasma glucose in the previous 3 months. So the patient receiving corticosteroid may be just hyperglycemia since 1 week, for example. In this situation, hemoglobin A1C is just a median for the numbers in the 3 months, but the hyperglycemia caused by glucocorticoid is just since 1 week. So in this situation, hemoglobin A1C will be a false negative result. So in patient with steroid, hemoglobin A1C is not accurate enough. What about the acute pancreatic damage? The same. So hemoglobin A1C is accurate in diagnosis for diabetes in adulthood only. So in children, in patient with steroid, in patient with acute pancreatic damage, in patient with a pregnant female, hemoglobin A1C accuracy is not enough. So in this situation, hemoglobin A1C may be not appropriate, steroid or antipsychotic, acute pancreatitis, pregnancy, patient with suspected of having type 1 diabetes, because type 1 diabetes is acute condition, acute hyperglycemia. Once the patient deterioration of the beta cell function since long duration, but acute hyperglycemia just since a few days. Children and young adults, hemoglobin A1C is not appropriate. Hemoglobinopathy, and also a short duration of osmotic symptom. But if hemoglobin A1C is elevated more than 6.5, this is a good marker for diabetes. But negative hemoglobin A1C, negative result, or normal hemoglobin A1C cannot exclude diabetes in this condition. So this is a very important. Hemoglobin A1C is accurate method for diagnosis of diabetes in type 1 diabetes, but if it is normal, it may be false negative result. Yes? Yes, Dr. Chavan, what about renal and the affection of hemoglobin A1C in this condition and blood transfusion? This condition will interfere with the result of hemoglobin A1C. And actually, I will cover it later on, inshallah, because in the GPDS guidelines, they mention that during the patient chronic kidney disease, for example, and on dialysis, what is the condition in which will cause pseudo elevation of the hemoglobin A1C, and what is the conditions which cause falsely low hemoglobin A1C. So in any conditions that interfere with hemoglobin lifespan may affect hemoglobin A1C. If the patient already received recent blood transfusion, will affect hemoglobin A1C value. If the patient with chronic kidney disease which causing a rapid turnover of blood RBCs and hemoglobin, will affect hemoglobin A1C falsely, and also erythropoietin will affect hemoglobin A1C, and so on. So don't forget that hemoglobin A1C is just a mean value for the previous 3 months of hemoglobin. So any factor that can affect this hemoglobin can affect hemoglobin A1C value.
So, excuse me, Dr. Khaled, why for acute pancreatitis this is not valid?
Because acute pancreatitis is a recent insult of beta cell. So beta cell damage is just since a few days, just since a few weeks, and hemoglobin A1C is a summary of the previous 3 months, not a few days, not reflect a few months, a few days. So in this situation, for example, as the steroid, the patient hyperglycemia since what duration? Since just a few days, which will not reflect in the hemoglobin A1C accurately. So in this situation, hemoglobin A1C is not accurate enough. So as mentioned by Dr. Ibrahim, hemoglobin A1C is a good positive test. If hemoglobin A1C is more than 6.5, this is a diagnostic for diabetes, but if it is normal, this not exclude diagnosis of diabetes. Another point about the classification of diabetes, and previously, since a few decades, we classified diabetes into 2 types: insulin-dependent diabetes and non-insulin dependent diabetes. But since 1997, these terms are obsolete. These terms are changing, because in this situation, insulin-dependent diabetes means type 1 diabetes, but we see a lot of type 2 diabetes later on, after 10 years, they need replacement therapy by insulin. In this situation, the term will be changed. The patient already in the insulin, and from the start, non-insulin dependent. So this term insulin dependent and non-insulin dependent are obsolete nowadays, and actually since more than 25 years. And actually classification of diabetes nowadays is just 4 categories: type 1 diabetes, type 2 diabetes, gestational diabetes, and other specific types. type 1 diabetes, which is mainly beta cell destruction, and usually the patient need insulin from the start, and can be classified into two types: autoimmune type 1 and idiopathic type 1, in which autoimmune antibody is negative, which is a little category of type 1. Type 2 diabetes, this is the most common type of diabetes, which is usually due to insulin resistance and relative insulin deficiency. So there is a secretory defect in beta cell with or without insulin resistance. Gestational diabetes, this is a hyperglycemia diagnosed during pregnancy, may be truly gestational diabetes or a pre-gestational diabetes and discovered during the pregnancy. And another specific types of diabetes which represent about 5 to 10% of all types of diabetes, like genetic defect of beta cell function, or genetic defect of insulin action, or disease of endocrine pancreas, or some of endocrinopathies like, for example, Cushing or acromegaly, or drug or chemical induced diabetes, or some infection, and some uncommon forms of immune related diabetes, and other genetic syndrome, which is other specific types. This is just a broad lines for etiological classification of diabetes, and I will cover it in more details in the following slides. So this is etiological classification of diabetes type 1 diabetes, which represent about 5 to 10% of all types of diabetes. So the most common, type of diabetes is type 2, which represent 90%. Type 1 is just 5 to 10% of cases, and this is usually due to the beta cell destruction. Once the patient is symptomatized, in this situation, about 80% of beta cell is destructed, and usually due to autoimmune destruction of beta cell. But to a little extent, it may be due to idiopathic form type 1. Both autoimmune and idiopathic form require insulin from the start. But don't forget that type 1 diabetes is not unique for young patients. So we can see type 1 diabetes in elderly or adults, but it most commonly presented in young patients. The same for type 2. Type 2 diabetes usually presented in adults, but nowadays we see a lot of cases in pediatric population with type 2 diabetes. So don't take an age as a marker for differentiation between type 1 and type 2. This is obsolete nowadays. So, for example, Theresa May diagnosed for type 1 diabetes since a few years. So, type 2 diabetes, which represent 90% of cases, usually due to the defect in the insulin secretion, and usually with defective insulin action, and usually presented in obese patient. Yes, I am with you.
Type 1, they discovered that it is diagnosed up to the age of 50 or more, Dr. Khaled?
More. Theresa May is diagnosed by type 1 in, I think, at the age of 55.
Okay.
So, age is not a criteria for differentiation between type 1 and type 2. How to differentiate, Dr. Shaban may ask about clinically how to differentiate between type 1 and type 2, and actually I will cover this later on. And actually NICE published a very important guideline about the type 1 and type 2 in young adults. And we will cover these guidelines later on. But inshallah today I will cover how to differentiate between type 1 and type 2. Dr. Sadeh, have you seen type 1 in 80-year-old? Actually, no. But it may be presented in some situations, but actually it's very, 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 very rare. So type 2 diabetes usually presented in obese, so cause insulin resistance with a family history of diabetes. In other types of diabetes, the most common is genetic defect of beta cell, which is a monogenic diabetes like MODY, maturity onset diabetes of the young, and in neonatal diabetes, this is a diabetes diagnosed before the age of 6 months, neonatal diabetes, and another one which is mitochondrial diabetes, which is maternally inherited diabetes, and I will cover this. So الجينيتك defect of the beta cell function MODY, mitochondrial diabetes and neonatal diabetes. Another genetic defect of insulin action lipodystrophy, which is caused by insulin resistance, severe insulin resistance, and I will cover it later on. And another very rare conditions in which insulin receptor mutation like Rabson-Mendenhall syndrome. And also monogenic obesity hyperphagia, which is leptin deficiency causing diabetes. And another conditions which is other forms of diabetes like exocrine disease of exocrine pancreas, like pancreatitis or trauma or pancreatectomy due to any cause, or neoplasia of the pancreas or pancreatic destruction can cause diabetes due to the exocrine pancreas. Another endocrinopathy which is presented by diabetes mellitus, the most important is Cushing syndrome, acromegaly, glucagonoma, hyperthyroidism, pheochromocytoma. So الكوشنج syndrome, الacromegaly, pheochromocytoma, hyperthyroidism, glucagonoma, and autoimmune polyendocrine syndrome type 1 and type 2 may be presented by diabetes. So this is a very important. LADA fall under which list, Dr. Shavan? Actually, in this classification, LADA is not actually presented. And this actually is, I don't know how they forget LADA, but I will cover LADA later on. So, LADA is not mentioned in this classification. Also, drugs or chemical-induced diabetes like glucocorticoid, thyroid hormone overuse, diazoxide, and some of the antiretroviral treatment drugs, beta agonists, thiazide, alpha interferon can cause diabetes. Infections that can cause diabetes, congenital rubella and cytomegalovirus, and also there is uncommon form of immune-mediated diabetes like Stiffman syndrome, which is presented by type 1 diabetes and originated of the muscle and painful spasm, and another one which is anti-insulin receptor antibody that can cause a fluctuation between hypo and hyperglycemia, anti-insulin receptor antibody. Another genetic syndrome associated with diabetes, and don't forget this, Down syndrome, Klinefelter, Turner, Wolfram syndrome, which is Diamond syndrome, Friedreich ataxia, Huntington's chorea, celiopathy, myotonic dystrophy, and I will cover some of this syndrome later on. And lastly, the fourth types of diabetes is gestational diabetes, which is a diabetes diagnosed during the pregnancy. And this actually is the same table, but different categorization from the Oxford textbook. They classify according to the etiology of the diabetes, autoimmune diabetes, and here they mention that LADA here is mentioned in this category as autoimmune diabetes like type 1, LADA, because in the latent autoimmune diabetes of adults, diabetes autoimmune antibody is positive. Monogenic autoimmunity. And another one is a type 2 diabetes, which is the most common one. Genetic defect of the beta cell MODY, neonatal mitochondrial diabetes. Genetic defect of the insulin like lipodystrophy, insulin receptor mutation, genetic severe obesity. Disease of the exocrine pancreas like pancreatitis and hemochromatosis and cystic fibrosis related diabetes. And this is a very important topic because in the exam they ask about how to manage cystic fibrosis related diabetes. And ISPED guidelines put a very important chapter about management of cystic fibrosis, which is managed by insulin. Endocrinopathy like Cushing, acromegaly, pheochromocytoma, and syndrome associated with diabetes like Down, Turner, Friedreich ataxia, Werner, and Alstrom syndrome. And actually, in I think 2016 they gave a question about Alstrom syndrome, and I will cover it later on, inshallah, in one of my sessions. And of course, drugs, corticosteroid is the most important one, but don't forget that the diazoxide, thiazide, antipsychotics, checkpoint inhibitor can cause diabetes, and I will cover checkpoint inhibitor in special guidelines published by European, I think, ETA guideline or endocrisis, ETA, I think. So the vast majority of patients with diabetes have either type 1 diabetes, which is about 5 to 10%, and type 2 diabetes, which is due to relative insulin deficiency, defect of the insulin secretion, insulin resistance, and about less than 10% another rare types, moody diabetes and gestational diabetes, and so on. I will cover it. Dr. Shavan asked about how to differentiate between the three types of autoimmune diabetes. And actually, as I mentioned from this table, we have three types of autoimmune diabetes: type 1, latent autoimmune diabetes of the adults, and monogenic autoimmunity. Both of these three conditions, beta cell antibody is positive. How to differentiate between type 1 and later is very important, and I will cover it later on in very important tables and algorithms. So this is actually from one of the important textbook of diabetes. Actually, this is the 5th edition. This is the last edition of the textbook of diabetes. And actually, this shows that we have a type 1 and type 2, and another types of diabetes have a specific feature of type 1 and a specific feature of type 2. For example, latent diabetes have specific types for type 2 diabetes. For example, it can be treated initially by oral medication. But actually, some of the criteria of type 1 diabetes, like beta cell antibody, so have some criteria of type 1 and some criteria of type 2. And actually, it is rapidly progressive to need insulin therapy like type 1. So LADA can be categorized as slowly progressive type 1. Slowly progressive type 1 can be treated by oral medication like type 2, but within 1 year need replacement therapy by basal bolus insulin like type 1 diabetes, and so on. And also, moody diabetes can be presented like type 2 diabetes, so can be treated by oral medication. And some types of moody diabetes can need no treatment at all, except in specific situation, for example, during pregnancy. And some of moody types need insulin from the start. The same for mitochondrial diabetes and amylin gene mutation. So this table summarizes how to differentiate between type 1 and type 2. And don't forget that the age is not a very rigid criteria for differentiation between type 1 and type 2. But we at least need to know that the peak age of onset for type 1 is 12 years of age. But the peak onset of type 2 is 60 years of age. But actually nowadays we see a lot of cases of type 2 diabetes in a young patient. Even in a patient less than 20 years of age. The prevalence, UK prevalence of type 1 is about 0.2%, but the prevalence of type 2 diabetes in UK is about 5 to 7%, and 10% in those patients more than 65 years of age. Initial presentation of type 1 usually presented by polyuria, polydipsia, weight loss, and ketoacidosis. About 25% of type 1 will be presented initially by DKE. But type 2 diabetes just presented by a hyperglycemia since a long duration, often may be presented by a macro or microvascular complications. So once we diagnose type 2 diabetes, we should search for complication. But type 1 diabetes complications, we will not screen for complications at least 5 years after the diagnosis of type 1 diabetes. But type 2 diabetes, we should screen for complications once we diagnose type 2 diabetes, because the beta cell dysfunction is started since long duration. Etiology of type 1 is just autoimmune beta cell destruction, but type 2 diabetes is a multifactorial condition. Insulin resistance, the main defect is insulin resistance, beta cell destruction, beta cell dysfunction. The presence of beta cell antibody is presented already in more than 90% of type 1 diabetes. So this is autoimmune diabetes. And this is a gold standard for differentiation between type 1 and type 2. presence of beta cell antibody, especially if more than 2 or 3 beta cell antibody. Type 2 diabetes usually presented with negative beta cell antibody. Of course, type 1 require insulin initially from the start, but type 2 can be managed by oral medication or non-insulin injectable therapy from the start, and later on may require insulin therapy. Of course, the DKA is usually presented in type 1 diabetes, but in type 2 diabetes, DKA is very, very rare. Once you diagnose DKA with type 2 diabetes, please search for very, very critical condition like cerebral stroke, myocardial infarction, severe infection. Type 2 diabetes is very, very rarely to be presented with DKA. Obesity is more common with type 2 diabetes, not common with type 1 diabetes, except in a specific population in which obesity is more prevalent. Insulin resistance is presented in type 2 diabetes. Treatment, of course, type 1 require insulin from the start. Type 2 diabetes require lifestyle modification plus oral medication or non-insulin hypoglycemic agents plus or minus insulin in some situation. So, if you see a patient newly onset diabetes in some patient and they presented by DKA in this situation, this is usually type 1 diabetes. If the patient is hyperglycemia with very osmotic presentation with very weight loss, in this situation, I will suspect he is type 1 diabetes. But if another patient presented by hyperglycemia since long duration, in this situation, I will suspect this is a type 2 diabetes, not type 1. If a patient, young patient, and obese, with a strong family history of diabetes, in this condition, I must suspect he may be type 2 diabetes, not type 1. But if the patient is presented in a young age, not obese, no family history of type 2 diabetes, this is a typical presentation for type 1. So, type 2 diabetes usually obese with a family history of diabetes, with some features of insulin resistance like acanthosis or polycystic ovary syndrome and so on. So this is table how to differentiate between type 1 and type 2, which is very important. And this algorithm is important. Actually, this algorithm is from the 3rd edition of Oxford Handbook, not presented in the 4th edition. In the 4th edition, there is another algorithm. This is one, but actually I put this from the 3rd edition because it have some of important data. So this algorithm is important, and this is from the Oxford Handbook of Endocrinology and Diabetes 3rd edition, not presented in the 4th edition. There is some modification for it in the 4th edition. So if you see any patient diagnosed the same criteria for diagnosis of diabetes before the age of 6 months, in this situation, this is a neonatal diabetes. And in neonatal diabetes, this is a diabetes diagnosed before the age of 6 months, can be classified into 2 types: permanent neonatal diabetes and transient neonatal diabetes. And some types of neonatal diabetes can be managed by sulfonylurea. So don't be surprised if you see a neonate with diabetes managed by sulfonylurea. This is a neonatal diabetes diagnosed before the age of 6 and can be managed. Some of the categories of neonatal can be managed by glibenclamide, for example. If diabetes is not diagnosed before 6 months, if the diabetes is diagnosed before the 45 years of age with a specific manifestation like deafness and a neurological feature, this is a pathognomic for mitochondrial diabetes. So in any patient with diabetes, with deafness and other neurological feature, we should suspect mitochondrial diabetes. If the patient answer is no, the patient presented by permanent insulin within 3 months of diagnosis and or beta cell dysfunction, positive beta cell antibody with diabetic ketoacidosis, in this situation, the most probably is type 1. Positive beta cell antibody with DKA, in this situation, this is mostly This is mostly type 1. But if in this situation C-peptide is elevated, is positive, C-peptide is positive, more than 0.2 nanomole per liter outside the honeymoon period, and beta cell antibody is negative, in this situation, I will consider specific types like Moody. If beta cell is not positive and the patient age is less than 30 years in diagnosis and absence of insulin resistance, this will exclude to some extent type 2. And there is a strong family history of young onset diabetes, I must suspect Moody. So in Moody, we have a very strong family history of diabetes diagnosed in a young, usually because this is an autosomal dominant condition, so father and grandfather, or mother and grandmother or grandfather from the mother, and diagnosed usually in the young onset. This is a Moody. If the answer of this condition is no, for example, if there is a presence of some feature of insulin resistance, I must suspect type 2 diabetes, which is the most common type of diabetes.
Dr. Khalid,
Yes?
if it's only present, if there is a history of diabetes in only mother side, we should suspect mitochondrial.
I will cover, Dr. Jamal, this point later on, because the mitochondrial diabetes actually is very rare, not common, and usually presented by some of the neurological manifestation like deafness, sensorineural deafness, some of neurological feature, and it is inherited maternally. So in this situation, the mother must have mitochondrial diabetes, and all offspring must have mitochondrial diabetes. So a mother which have mitochondrial diabetes will inherit this condition to all of his spring. But if the father has mitochondrial diabetes, will not inherit the mitochondrial diabetes to his children. I will cover it later on, inshallah. The modification of the previous table, and this actually is already available in the fourth edition of Oxford Handbook of Endocrinology and Diabetes, and actually I extract this algorithm from the textbook of Endocrinology and Diabetes, the latest edition. Dr. Shafam, I will cover genetic testing for neonatal diabetes later on, because it is very important, and in the Oxford they mentioned a specific website for diagnosis genetic testing for Moody and neonatal diabetes. Dr. Hatim asked about how I attend this lecture regularly and there is any fees. Actually, this is a paid course, Dr. Hatim, and if you with us in the WhatsApp group, I mentioned several times how to contact this course, paid course. And if not in the, please send me a message and I will send you the link. So how to investigate a new diabetes diagnosed before the age of 30, according to the this algorithm. Beta cell antibody, dead and insulinoma associated autoantigen type 2, and check C-peptide if insulin is treated. If any positive antibody, if C-peptide is negative, in this situation, probably type 1 diabetes. And actually, C-peptide is positive if plasma C-peptide is more than 200 picomole per liter or more than 0.6 nanogram per milli, or a positive urinary C-peptide more than 0.2 nanomole per millimole. So this cutoff points for positive plasma C-peptide or positive urinary C-peptide. So if there is beta cell autoantibody and negative C-peptide, in this situation, probably type 1 diabetes. If there is antibody is negative and C-peptide is positive, in this situation, we should look for a clinical feature. If the patient is obese, body mass index is more than 30 kilogram per cubic meter, with a feature of insulin resistance, hypertension, dyslipidemia, hepatic stenosis, polycystic ovary syndrome. In this situation, most probably type 2 diabetes. If no, I will look for a classical MODY. The classical MODY will be presented as lean body weight, C-peptide will be positive, the antibody will be negative. Often, family history of diabetes diagnosed before the age of 45, and DKA usually is not presented. And we have very common two types of MODY, GCK or glucokinase MODY, and another one which is hepatocyte nuclear factor types MODY. Glucokinase MODY usually presented asymptomatic, mild fasting hyperglycemia, the fasting blood glucose just between 5.5 and 8. So the fasting blood glucose in MODY glucokinase is just mild hyperglycemia. Hemoglobin A1C usually is less than 58 millimole per mole. And there's a family history of impaired glucose or gestational diabetes. This is a glucokinase MODY. But hepatocyte nuclear factor 1A, 4A usually require treatment by sulfonylurea. C-reactive protein usually negative for HNF1A. There is hyperinsulinase for neonates and hypermacrosomia for hepatocyte nuclear factor type 4A. So this is a pathogenomic for hepatocyte nuclear factor 1A and 4A. But if this diabetes plus other feature like, for example, for mitochondrial diabetes, deafness, other neurological myopathy, and maternal inheritance, I would suggest mitochondrial diabetes. If there is a severe insulin resistance, I will suspect lipodystrophy. And HNF1 beta MODY, this is usually presented by renal cyst, renal disease, genitourinary anomalies. So this is how just a wide approach to differentiate between different types of diabetes. And usually in the exam, they will give a scenario and ask about which type. So if you see cystic renal cyst with genitourinary anomaly, suspect HNF1 beta MODY. If you see a case with asymptomatic mild fasting hyperglycemia, this is a glucokinase MODY. If a patient presented by neonatal macrosomia, you should suspect HNF4 alpha. If they mention that a patient presented by mild hyperglycemia and the patient required treatment and C-reactive protein is negative, in this situation, I will suspect HNF1 alpha. I will repeat this a lot of times today, inshallah, and I will cover, give a lot of tables to memorize this before the finish of this session. Dr. Shavan asked to repeat this slide, and actually, Dr. Shavan, I will send the link later on, inshallah, for all of you, and also I will cover it several times later on because I think the presentation is very long, so I will go to it later on. And diabetes genetics is very important because in each exam they will ask a question about the diabetes genetics. And this is a question from exam lab, and the exam lab, as I mentioned, is very important source for before the exam. And actually, this is just a 200 question exam lab. In each exam, they will pick up randomly about 20 to 30 questions from the exam lab and put it in the exam as it is. So here they mentioned that we have a woman, a 26-year-old woman with type 1 diabetes was seen in the antenatal diabetes clinic. She is pregnant in the first trimester. The father of her child also have type 1 diabetes. So the mother type 1, father type 1. They were concerned that their child might develop type 1 diabetes mellitus. What is the likelihood of the child developing type 1 diabetes? if the mother and the father have type 1, what is the risk for development of type 1 diabetes for this child?
B. 5 to 10%.
Dr. Ashraf and Dr. Najah, type B, 5 to 10%. Actually, this is a very, very low percent for father and mother.
Doctor, if the mother percentage, I think 1 to 2%. If
Yes.
the father, 3 to 6%.
Yes.
If both, I didn't know, and take the 5 to 10%.
5 to 10 is less. As you mentioned, as you said, Dr. Najah, if the father is type 1, the risk of his offspring is about 6%.
Yes.
So if the father and mother, you must suspect that the risk is more and more. But
25
actually,
to 40 maybe.
I can accept your answer, and I will cover actually your answer in the next slide, Dr. Najah. But in his exam lab, actually, the answer is 25 to 40%. 25 to 40%. And this is the correct answer regarding exam lab. But in the last edition of the Williams, textbook of endocrinology, they mentioned that if there is risk for type 1 diabetes, if both parents are type 1, the risk is about 10%. So there is a sum of conflicting in this point. So I can accept your answer as you mentioned 10%, Dr. Najah, because William textbook of endocrinology mentions that if both parents are type 1, the risk for children to be type 1 is about 10%, and this is acceptable practical answer. But actually in the exam lab, which is correct for the exam, if both parents are type 1, the risk likelihood for development of type 1 diabetes in this situation is 25 to 40%. So in clinical practice, I am with 10% only. But in the exam, I will answer the same as exam lab. Okay? How to explain the percentage? I don't know, Dr. Shavan. So in the exam, just memorize the numbers as it is. So I will cover when the father is type 1 diabetes, what is the likelihood for children and for the mother, and if both parents, don't forget that if both parents are type 1, the answer will be 25 to 40% in the exam. But in your clinical practice, if you have a patient presented with type 1 diabetes and has her husband type 1 diabetes, and they ask about likelihood for development of type 1 diabetes of his offspring children, please answer by less than about 10%, not more. So and you can answer it by, for example, if you born 100 children, only 10 children will be affected by type 1 diabetes. So not to magnify the problem.
Dr. Khalid, in this table, from William, I think,
yes,
father percentage in childhood
is 4.6, but actually it is about 3 to 6, and I will cover it later on according to the Oxford Handbook. So if the overall lifetime risk for development of diabetes in the Caucasian population is about 0.5%. This is a general population development of type 1 for Caucasian. If the mother has type 1, the risk for increase to be 1 to 2%. If the father is type 1, the risk will be 3 to 6. If a sibling has type 1 diabetes, the risk will be 5 to 6. If monozygotic twins have one of the monozygotic twins have type 1 diabetes, the risk will be about 50% for another twins by the age of 40 years of age. So this table, this number is very important because in each exam they will ask a question like this.
Monozygote twins in type 2 more than type 1.
Yes, more than six. I will cover it. More than 60 to 90% or 80%, and actually it may be 100%. So in a previous exam in 2017, in each exam they will ask a question about these numbers. In 2017, they ask about a risk of diabetes if the father is type 1, so it is 3 to 6. If the mother is type 1, the risk will be 1 to 2. If the father and the mother type 1, the risk will be 25 to 40%. This is for the exam. For monozygotic twins, if one has a type 1 diabetes, the risk to another twins will be 50%. And in 2016, they give a question, a male, and they ask about what is the chance of inheritance to his kids. And actually the question asks about the least chance of inheritance, MODY or mitochondrial diabetes. The patient is male. So MODY diabetes, what is the mode of inheritance of MODY diabetes? Yes.
Autosomal dominant.
Yes, so autosomal dominant, what does we mean by autosomal dominant? Risk of inheritance of diabetes is about 50%.
50%.
So if the father is diabetic, MODY diabetes, the risk of inheritance to his children will be 50%. What about mode of inheritance of mitochondrial diabetes?
Maternal.
What does we mean by maternal?
From the mother. Mutation.
So inheritance only through the mother. So if the father is presented by mitochondrial diabetes, the risk of inheritance to his children will be 0%.
0%.
So this is important. So if the male patient presented, the risk of inheritance of MODY is 50%, the risk of inheritance for mitochondrial diabetes will be 0%. So the risk of inheritance for MODY is more and more than in mitochondrial inheritance.
Must be the mother has mitochondrial diabetic, not type 1 or type 2 or other type.
Mitochondrial.
Yes.
This is a specific types of diabetes. So type 1 diabetes usually have a HALA gene plus 2, and most of loci is DR and DQ loci. But DR usually 3 and 5. So HALA class 2, DR is 3 and 5, and another specific types of DR and DQ loci. Numbers is not very important, but we should know that HALA class 2, DR is 3 and 5. And so we have another question from the Atul book. This is a 26-year-old Caucasian man with a background history of type 1 diabetes. Keen to know the risk of his offspring developing diabetes. He is man. His wife does not have diabetes. What is the risk of developing type 1 diabetes in a father with type 1?
C, 3 to 6.
Yes, 3 to 6. So the right answer is 3 to 6. And this table is one of another very important slide in my presentation. The first one is diagnostic criteria for diabetes. The second one is this one, inheritance rate of type 1 and type 2. So for the concordance rate in monozygotic twins, 50% for type 1, but it is 60 to 100% for type 2. If the mother has diabetes, the risk for type 1 is 1 to 2%, but for type 2 is about 25%. If the father has diabetes, the risk for development of type 1 is 3 to 6, but if the father has type 2, the risk for the children to be diabetic is 25%. If both father and mother has type 1, the risk of inheritance for his children will be 25 to 40, but for type 2, it will be 60 to 80% for type 2. Concordance rate, it means the risk of inheritance of diabetes to both one has a diabetes and another is not. Concordance rate, a risk of development of diabetes to another twins. So if we have monozygotic twins, one of them have type 1, the risk for another one will be 50%. But for type 2, 60 to 100%.
Doctor, excuse me, if the both parent has diabetes,
Yes.
what is the percentage of type 2 diabetes, development of type 2 diabetes?
60 to 80%.
200.
Shukran.
And I will cover it later on, inshallah. Actually, type 2 diabetes is inherited disorder. Risk of inheritance of type 2 is more and more than type 1. Type 1, risk of inheritance is very little, but type 2 is inherited disease. So any child, obese child, have a father with diabetes, the risk of inheritance to be type 2 diabetes is about 25%. And actually this percentage will be increased and more if the child have a lack of lifestyle modification. And of course, stressful condition and environmental factor will affect this percentage. So we have another question from the exam lab, and they ask about 52-year-old woman had been found to have type 2 diabetes approximately 6 months previously. Hemoglobin A1C is 50 millimole per mole. So this elevated hemoglobin A1C. What is the lifetime risk for her identical twin sister also developing type 2 diabetes?
More than 60%.
So yes. So the risk for development of type 2 diabetes in identical twins will be more than 60%. So the concordance for type 2 diabetes for monozygotic twins is 60 to 80, 100%. And the heritability of type 2 diabetes is estimated to 25%. And more than 100 genetic susceptibility variants for type 2 diabetes is already present. So, and this actually is a question in the previous 2021 exam. They asked about type 2 diabetes in identical twins. So it will be 60 to 100%. And a question from the study PRN. Study PRN, one of the important question banks before for preparation for the exam. This is a 35-year-old school teacher referred to the clinic for assessment and management of diabetes. She diagnosed since 3 years. She have a good glycemic control on oral hypoglycemic therapy. She never experienced ketosis. She has an elder sister who have diagnosed with diabetes since 12 years, previously at the age of 24. Blood pressure is okay, but the blood pressure index is 25.5. So the patient is not obese. The diabetes is well controlled. There is a family history of diabetes diagnosed in young age. His current medication is just metformin 1 gram twice a daily and the gliclazide 80 milligram twice a day. Hemoglobin A1C is not elevated, highly elevated, it's just 7.5 or which is equivalent to 58.5 millimole. So in exam, they will give you equivalent percent of hemoglobin A1C, and also they will mention the reference range, normal reference range. The fasting plasma glucose is just mild elevated, 6.9, and of course the diagnostic criteria for diabetes is fasting blood glucose. What is the diagnostic criteria for fasting blood glucose?
More than 6.
The fasting blood glucose diagnostic for diabetes.
More than 7.
Seven.
More than 7.
But yes. Normal fasting blood glucose is less than 6.1 for the WHO and NICE, but for American is less than 5.7. The total cholesterol is normal or mildly elevated. TSH is low. TSH receptor antibody is negative, so this is not a grave disease. GFR is normal with the GAD antibody is negative. So what of the following is the most likely correct diagnosis? Is it type 1? This is my question.
No.
Why
No,
not type 1? Why not type 1?
Antibody is negative.
Get antibody is negative.
And
Yes,
also
registration.
another why not type 1 also? And
Patient
actually,
already on
don't forget that
oral tablet.
the patient is diagnosed since 3 years. Even for type 1, after 3 years of the diagnosis, the autoantibody usually will resolve. So don't depend upon the get antibody after 3 years of diagnosis of diabetes actually. So the patient already in metformin and glycoside. So this will exclude the type 1 actually. And of course, the get antibody will exclude it. So which of the following is the most likely correct diagnosis? Is it type 2? Is it type 2?
No.
Why no?
Patient not obese and has 2 sisters, has diagnostic early in.
But actually, we cannot exclude type 2 by the weight only. Actually, we cannot exclude type 2 100%, but it mostly not type 2. So it is not excluded 100%. But probably if type 2 is less than another types. What about, is it latent autoimmune diabetes in adults?
LADA, patient start by oral hypoglycemic and the progressive symptoms and become worsening. And
so is it LADA or not?
No,
no, patient stable.
The most important LADA usually presented by get antibody positive. This is autoimmune diabetes, so the autoantibody usually must be positive. And this is a slowly progressive type 1. So within 1 year, 1 or more years, the patient require insulin therapy. So in LADA autoimmune, and I will give the diagnostic criteria for it. What about Schmidt syndrome? Is it Schmidt syndrome? Schmidt syndrome, what does we mean by Schmidt syndrome?
There has to be hypothyroidism and Addison
disease. Yes. So Schmidt syndrome, I will cover it. Schmidt syndrome, this is autoimmune polyendocrine syndrome type 2, and I will cover it later on in another chapter, inshallah. This is usually Addison, type 1 diabetes, which is autoimmune type 1 diabetes, and chronic thyroiditis. So Schmidt syndrome is autoimmune polyendocrine syndrome type 2, usually presented commonly Addison, type 1, chronic thyroiditis. But autoimmune polyendocrine syndrome type 1, this is candidiasis, hypoparathyroidism, and Addison's disease, and usually presented by gene ARY gene. This is a very important gene, and we will cover it. So why this is moody? Why this is moody? Because the patient is not obese, the patient is young, there is a strong family history of type 1 of diabetes presented in a young age, and already in metformin and oral sulfonylurea, and the autoantibody is negative. So this is must be suggestive. Dr. Iman asked, I cannot understand why this is not type 2. Actually, it may be type 2, but as the patient is not obese and well controlled on metformin and sulfonylurea, and the diabetes is not deteriorated within the 3 years, this is may suggest another types of diabetes, not exclude type 2 diabetes. So I can diagnose it as type 2. But in this situation, we must think about another forms of diabetes.
I think type 2
in this scenario, we cannot conclude it is moody before genetic testing. Yes?
I think there is a calculator for doing that, for checking if a patient has got.
Yes, Dr. Ashraf?
Is a calculating count of.
Yes, I will give a calculator, inshallah, after a few slides. This is just a probability of moody, not a conclusive criteria for diagnosis of moody. At the end, moody should be diagnosed genetically. Genetical analysis. This is the gold standard for diagnosis of moody and neonatal diabetes and so on. But at least in this scenario, this is a feature suggestive that this patient may be MODY diabetes, not type 2. So, MODY diabetes, this is a very important topic in the exam. And in general practice, you may diagnose some types of MODY and previously diagnosed as type 2. So it is very important in clinical practice and exam. Yes, I will illustrate MODY types and different forms, inshallah, Dr. Ayman. So in each exam, you will face 3 to 4 questions about MODY diabetes. So MODY, this is the commonest cause of monogenic diabetes. Monogenic diabetes means diabetes that inherited by a single gene. We have 2 common types of monogenic diabetes: MODY diabetes, which is maturity onset diabetes with the young, and the neonatal diabetes, which is a diabetes diagnosed before the age of 6 months. MODY diabetes represent about 0.5 to 1% of all patients with diabetes, usually presented before the age of 45 years, usually frequently before the 25 years, but some cases can be diagnosed after that. Because most of cases, glucokinase MODY, for example, presented by mild hyperglycemia, and most cases not require treatment, so can pass unnoticed until diagnosed after this age. MODY diabetes is diagnosed by autosomal dominant. So there is a strong family history of diabetes in more than 2 generations. And also usual absence of autoimmune marker, which is unique for autoimmunity type 1 and LADA diabetes. And also absence of insulin resistance, because insulin resistance is a criteria for type 2. And also C-peptide will be positive like type 2, not type 1. The most important types of MODY diabetes is heterogeneous mutation in gene encoding enzyme glucokinase, GCK. And another one, which is a nuclear transcription factor, hepatocyte, a nuclear factor, 1 alpha, 4 alpha, 1 beta. And actually, so glucokinase, HNF, 1 alpha, 4 alpha, 1 beta. Each one called MODY 1, MODY 2, MODY 3, MODY 5, and so on. So we have 12 different types of MODY. The most important types is 4 types: glucokinase, hepatocyte nuclear factor 1 alpha, 4 alpha, and 1 beta. So how to differentiate between those 4 types of MODY is very important in the exam. In each exam, they will give a different types of MODY. So I just mentioned what is the difference between autosomal dominant and autosomal recessive. In any patient in any disease presented by inherited by autosomal dominant, one single parent affected by the disease will inherit to 50% for his children. So boys will inherit the disease 50%, girls will inherit the disease 50%. This is very important. But for autosomal recessive, the disease to be presented must have 2 affected genes. If the father is carrier and the mother is carrier, the risk for his children to be affected is 25% only. And 50% will inherit the disease as a carrier, and the 25% will be free from the disease. So this is a very important. So in another condition, if the disease is inherited as autosomal recessive and the father is affected and the mother is not a carrier, in this situation, what is the condition? No children will be affected. Just 50% will be a carrier and 50% will be a normal. If the father is diseased by autosomal recessive disease, in this condition, 50% will be a carrier and 50% will be normal. But if the father is diseased and the mother is a carrier. In this situation, you will check it and you will find that in this situation, this is will be affected, another will be affected, another will be carrier, last one will be a carrier. So you cannot do this mathematical calculation easily if you memorize this figure. So the genetic etiology of the MODY, the most common type is transcription factor MODY, which represent about 60% of the MODY. Glucokinase is the second commonest one, which represent about 28%. But a transcription factor, we should know that we have 3 common type: hepatocyte and nuclear factor type 1 alpha, 4 alpha, 1 beta. 1 alpha is the most common type, which represent about 46%. So in 1 alpha to some extent equal to glucokinase MODY diabetes. And another types, very rare types, so you need to memorize glucokinase 1 alpha, 4 alpha, 1 beta. This is the most common in the exam, and actually this is the most common in general practice. Let's start by hepatocyte nuclear 1 alpha MODY, which is previously named MODY 3. And actually in the exam, they will not mention MODY 3. They will ask about hepatocyte nuclear factor 1 alpha MODY. They will not give you MODY 3 and MODY 5 and so on. Will ask about hepatocyte nuclear factor 1 alpha. So I will start by MODY 3, which is hepatonuclear factor 1 alpha. And actually this is a very important topic. This is account about 30 to 70% of types of MODY associated with progressive defect of insulin secretion, and the treatment required. Vascular complications are similar rate as in other types of diabetes, and the most specific criteria is low renal glucose threshold. So, for example, patient may be presented by blood sugar 150 and there is a glucosuria, and the C-reactive protein is negative. And of course, this type of MODY is sensitive to sulfonylurea, so the patient will be controlled on a low dose of gliclazide, 20 to 40 milligram per day. And this is the first line pharmacological therapy. So in the exam, they may give a scenario: a young patient presented by a newly onset diabetes with low renal glucose threshold and low C-reactive protein, and ask about how to manage the first line therapy. So the first line therapy, sulfonylurea, not metformin as type 2 diabetes. So a low dose of sulfonylurea will be recommended as a first line therapy for HNF 1 alpha MODY. And of course, if you diagnose this patient as type 1, you will start by insulin. But in this situation, if you suspect it is a MODY and diagnose it as a MODY 1 alpha, you can stop insulin and give a small dose of sulfonylurea. A second line treatment will be metformin or DPP-4 inhibitor. And as existing low renal glucose threshold, SGLT2 inhibitor treatment may be less effective than in type 2 diabetes, or may cause a dehydration. And actually in 2022 exam, they ask a question about diagnosis of MODY. Another type of MODY, which is MODY 1, which is HNF 4 alpha. This is a not common type of MODY, represent 5 to 10% of MODY. Clinically as 1 alpha MODY, except normal renal glucose threshold, normal CRB. So in MODY 1 alpha, CRB will be low, low renal glucose threshold, and also sensitive to sulfonylurea. But the most specific criteria: affected offspring have hyperinsulinemia in utero, leading to macrosomia and neonatal hypoglycemia. So in any pregnant female present for previous history of macrosomia, you should suspect HNF for alpha. And also if she have a neonatal hypoglycemia. So HNF for alpha, the most specific criteria: normal CRP, normal renal glucose threshold, macrosomic baby, neonatal hypoglycemia, hyperinsulinemia in utero. So this is the most criteria for alpha. For 1 alpha, I will repeat it. Vascular complication is common, low renal glucose threshold, low CRP. The first pharmacologic therapy for HNF 1 alpha and 4 alpha will be low dose sulfonylurea. The second line therapy, metformin or DB4 inhibitor. SGLT2 inhibitor is not approved for HNF 1 alpha. A glucokinase MODY, this is a MODY 2, previously known as MODY 2, and this is a very common clinical case scenario in the exam. This is the most type in the exam. About 30 to 70% of the MODY presented, the main criteria is stable, mild, fasting hyperglycemia. Fasting blood sugar usually less than 8. If you want to convert to milligram per deciliter, please multiply by 18. So, fasting blood glucose is mild fasting blood glucose and low increment of glucose rise following carbohydrate challenge. In the oral glucose tolerance test, a 2 hour is just mild elevation than fasting blood glucose. So a glucokinase MODY raised glucose threshold for glucose stimulated insulin secretion, but importantly insulin secretion remains regulated. So the patient usually have a lifelong mild stable fasting hyperglycemia. Hemoglobin A1C usually less than 7.5. Hyperglycemia in a glucokinase MODY can be diagnosed at any age. Patient usually asymptomatic. Hyperglycemia just discovered incidentally, for example, during pregnancy or during medical review or hospital admission. Diabetes-related microvascular complications are not observed. This is different than 4 alpha. Patients don't require any treatment. Glucokinase except during pregnancy may require insulin therapy. So this is a very important glucokinase. So glucokinase, what is the criteria for glucokinase MODY? Mild, stable, fasting hyperglycemia, low increment of glucose after glucose load. The patient usually asymptomatic, just discovered incidentally. The complications, the microvascular complications is not observed, not require treatment except during pregnancy, and I will cover management of MODY during pregnancy later on. And actually in the exam, this is a favorable MODY in the exam. In 2022, they ask about MODY glucokinase, and in 2021, they ask very different scenarios about different types of MODY. 4 or 5 scenario questions in the exam asking about what type of diabetes, whether ketosis prone, type 1, type 2, or MODY, which is the glucokinase, HNF 1 alpha, 1 beta, which is manifested, 1 beta manifested by renal cyst. You should know how to differentiate between these types by repeated scenarios. 1 beta MODY, which is previously known as MODY 5, this is known as RCED, ORCAD, renal cyst and diabetes. So ORCAD means renal cyst and diabetes. This is a very common scenario in the exam. What is the once you see this in the exam, you should suspect HNF 1 beta renal cyst. Renal cyst, genital tract malformation, pancreatic hypertrophy, exocrine insufficiency, hyperuricemia, raised liver function test, hypomagnesemia, neurodevelopmental, or behavioral disorder. Forget all of this. Renal cyst, genitourinary malformation. This is the most important items in the clinical case scenario. Once you see renal cyst, this is a modified or HNF1 beta. Not sensitive to sulfonylurea like 1 alpha and 4 alpha. Oral agent may be used as in treatment as in type 2. There is no evidence based to determine treatment, so oral agent may be used as in type 2, but insulin treatment is usually required within a few years of diagnosis, like LADA diabetes. So 1 beta MODY presented, other name is ARCAD, renal cyst and diabetes. ARCAD, renal cyst and diabetes, represent 5 to 10% of the MODY. Half of them are caused by whole gene deletion. Presented by renal cyst, genital tract malformation, hypomagnesemia, hyperuricemia, and neurodevelopmental disorder, not sensitive to sulfonylurea. So we start by metformin like type 2 diabetes, and insulin usually required later on. So in 2016, they asked a question about inheritance of MODY, which HNF1 beta, autosomal dominant. And another question in 2021, other one was a strong family history of diabetes, require insulin from the start. Renal and uterine abnormality. Once you see renal abnormality, you must suspect HNF1 beta. Diagnosed diabetes in her 20s, so sure you suspect modified, but no HNF1 beta in the choice, so it was so confusing. So this is a modified. But if modified is not present, so I would like to choose 1 alpha or 4 alpha. I will choose 4 alpha because it is more common. So this is 1 alpha more common, 30 to 70%. 1 beta is just 5 to 10%. So if you confused 1 alpha or 4 alpha, please choose 1 alpha because this is more common, especially if the patient and the 4 alpha usually presented by, will mention that there is a history of macrosomia or neonatal hypoglycemia.
Yes, Dr. Khaled, what do you mean by normal renal threshold? I was not sure about that.
Usually nephrons and the renal kidney excrete glucose through the nephron if blood sugar is more than 170. In the 1 alpha, this type 1 alpha, the kidney will excrete glucosuria less than 170 milligram per deciliter. So if blood sugar 140, in this situation you will find glucosuria. So this is what we mean by low renal glucose threshold. So in HNF1 alpha MODY, you will find glucosuria and the random blood sugar is just mildly elevated, not reach 170 milligram per deciliter. Don't forget, I am familiar with milligram per deciliter, not millimole per liter. But in the exam, you should know the millimole per liter as a reference range for blood sugar. So HNF1 beta MODY, this is ARCAD syndrome, renal cyst and diabetes, or modified. Another rare types of MODY, which is a mutation in the gene encoding beta cell potassium ATPase channel, ABCC8 and KCNJ11. Don't forget that this is KCNJ11. This is for neonatal diabetes. This is a gene mutation for neonatal diabetes. And this gene mutation denotes that the patient require sulfonylurea to be controlled, not insulin. So in a patient presented with a neonatal diabetes and KCNJ11 mutation, the patient will respond well to metformin. So I will give some of important tables to summarize this, and this actually from the last edition of the textbook of diabetes the fifth edition, the extra pancreatic feature. So in HNF1 alpha, low renal glucose threshold, there is a glucosuria within lower random blood sugar, raised HDL cholesterol, raised cardiovascular risk in excess of type 2. For alpha, the patient presented neonate with macrosomia or increased birth weight, macrosomia, neonatal hypoglycemia, low HDL cholesterol, low lipoprotein A1 and A2, and raised LDL cholesterol. HNF1 beta, renal cyst and renal development disorder. So I will go to some of the summaries of all types of MODY, and actually if you need another third table today, inshallah, this is one. And actually this is the most important slide in my presentation today. So how to differentiate between different types of MODY is very important. HNF for alpha, which is MODY 1, glucokinase, which is MODY 2, 1 alpha, which is MODY 3, IBF1, which is MODY 4, ignore it, HNF1 beta, which is MODY 5, KCNJ11, which is neonatal diabetes. So the most important to memorize glucokinase, which is the most common like HNF1 alpha. Glucokinase presented by mild fasting hyperglycemia, just mild elevation of the fasting blood sugar, no risk for development of microvascular complications. The hemoglobin A1C usually is less than 64 millimole per liter. HNF1 alpha, which is MODY 3, this is also the most common cause of types of MODY like glucokinase, associated with a progressive decline in beta cell, risk of microvascular complications increase, marked sensitivity to sulfonylurea. For alpha, this is progressive cell decline, but presented by neonatal hyperinsulinemia, neonatal macrosomia, hypoglycemia, and responsive well to sulfonylurea. 1 beta not responding to sulfonylurea, treated like type 2 diabetes, and presented by renal cell and renal cyst and genitourinary tract malformation. KCNJ11, this is a neonatal diabetes diagnosed before the first 6 months of the life, and responsive well to sulfonylurea, specifically glibenclamide. And how to transit from insulin to glibenclamide, this is a very important protocol in a very important book for pediatric endocrinology, which is Pediatric Endocrinology, K-Spring. The author is K-Spring.
Doctor, please.
Yes.
neonatal diabetes اللي هو sensitive to sulfonylurea، يعني لو أنا في يعني if there is neonate suspecting to be diabetic before 6 months or within first 6 months, I ask this genetic studying.
Yes, initially we should go to genetic study. We should start by insulin therapy and go to the genetic study. If there is a mutation in KCNJ11 gene, in this situation we can transfer to sulfonylurea. And actually I can share this slide, Dr. Ayman. You can go, and I will go to this book.
When we ask about genetic studying, we just ask genetic studying يعني full stop ولا بن describe أو بنعمل mention
genetic study. Usually when we ask genetic study, I will give the website. Actually we will give a genetic study for confirmation of neonatal diabetes. We should mention to what we should search for. Now I will go for, yes.
Oh, thank you, doctor.
This one, I think this one.
But Dr. Khaled, until result come, we can start with.
Yes.
Dr. Khaled, until result come, we can start with insulin.
We should start with insulin. We should start with insulin.
Yes, until
in every type with diabetes, we should start with insulin therapy. And after genetic analysis, if they mention that this is a KCNJ11 mutation, we can convert him to oral sulfonylurea. And actually, I think this is not one. This is one edition. I don't know, is it third or fourth? I think 5th edition.
Spamming fourth edition, Dr.
I think fourth edition, yes, I am fourth edition. I think it is the fourth. I think this is the third edition. I have already fourth edition. I can search for it. So I will put the protocol how to diagnose it later on, but it is in the spring textbook of pediatric endocrinology. It is give a very important protocol how to transit from insulin therapy to sulfonylurea and dosage of sulfonylurea and so on in the case of neonatal diabetes. And actually, this is also a very important table from the American guideline published in 2022. The different forms of MODY diabetes glucokinase, HNF, 1 alpha, 4 alpha, and 1 beta, the same, I think the same. And each type, so don't forget that glucokinase just stable, non-progressive, mild elevation, fasting blood sugar, not required treatment in most cases, except during the pregnancy. And most importantly, small rise in 2-hour post-oral glucose tolerance test on oral glucose tolerance test. So just elevation of blood sugar after 2 hours less than 3 millimole per liter. So this is very important. For example, if the fasting blood sugar is 6, in this situation, a 2-hour post-oral glucose tolerance test not more than 9. And this is a diagnostic criteria for glucokinase MODY. 1 alpha is lower renal threshold for the glucoseuria, large rise in 2-hour post glucose level on oral glucose tolerance test more than 5, and sensitive to sulfonylurea. 4 alpha, neonatal hypoglycemia, neonatal macrosomia, large birth weight, and sensitive to sulfonylurea. HNF 1 beta, all of them are autosomal dominant, genitourinary abnormality, renal cyst, atrophy of the pancreas, and hyperuricemia and gout. So if you see hyperuricemia and gout, think about HNF 1 beta. How to manage MODY in the pregnancy? We should have a high index of suspicion to screen for MODY in women without the usual risk factor for gestational diabetes. For example, a lean woman who present ill in the pregnancy, in this situation, or isolated fasting hyperglycemia may have glucokinase MODY, and in this situation, we will diagnose diabetes, or we should suspect is it a MODY diabetes. And of course, to diagnose MODY, we should transfer to genetic testing through this website, www.diabetesgenes.org. And I will go to this link later on because it has a very important calculator to risk of development of MODY in some condition. So for those with HNF 1 alpha, 4 alpha MODY already well controlled on low dose sulfonylurea prior to the pregnancy, there is a good argument for using glibenclamide. As we know, glibenclamide is categorized as category B during pregnancy, so it is safe. So if we have HNF 1 alpha or 4 alpha in this situation and well controlled on glibenclamide, we can continue glibenclamide through the pregnancy because it is safe. But don't forget that glibenclamide may cross the placenta and increase the risk of macrosomia. So neonatal screening is very important, and it is recommended to convert to insulin for the final trimester. In HNF for alpha MODY, an affected fetus can develop hyperinsulinemia and macrosomia and neonatal hypoglycemia. So the screening after delivery is very important for neonatal hypoglycemia. The glucokinase usually need insulin therapy during the pregnancy, and also treatment by insulin is recommended if there is a macrosomia, and I will cover this topic actually in a very important guidelines published by the NICE about diabetes during the pregnancy. This is a very important guideline, how to manage diabetes during the pregnancy according to the NICE, because it is very important in the exam and actually in the clinical practice. And actually, this is another table from one of the most important references for diabetes mellitus, which is textbook of diabetes. And actually, DeFronzo, this is DeFronzo, Ralph DeFronzo, the main editor of this textbook. International textbook of diabetes have a very important chapter about Ilmodi diabetes. And actually, if you need to understand Ilmodi diabetes, please read it from this textbook. International textbook of diabetes. Actually, this is one of the most important references for Ilmodi diabetes. And actually, I give some of tables from this book. So this is how to comparison between glucokinase MODY and transcription factor MODY. So the first one, both of them are autosomal dominant. Both of them are due to the loss of function mutation in glucokinase, here for glucokinase, or HNF 1 alpha or 4 alpha gene for MODY 1 alpha and 4 alpha. The onset of hyperglycemia glucokinase from the birth, but may be discovered in the before the 45 year. But for a transcription factor, usually diagnosed in the second and third decade. For a glucokinase MODY, usually asymptomatic, detecting during ordinary screening, but transcription factor MODY usually symptomatic. The hyperglycemia for glucokinase usually mild, stable hyperglycemia. The fasting usually less than 8 millimole per liter. Minimal increase in glycemia with age, parallel to the normal. The hemoglobin A1C usually is less than 7.5 or 7.7, and of course mild increment with oral glucose tolerance test, less than 3. The transcription factor usually severe fasting blood glucose, usually more than 14 millimole per liter of the treatment, and the progressive deterioration of glycemia with age, and hemoglobin A1C usually variable, usually high, like type 2 diabetes. So I repeat all data, Dr. Ayman, because this is a very important topic actually. And actually in the revision, I will not repeat it. So we have a lot of time nowadays. So we have a lot of time till the exam. So we repeat it several times to be memorized. The pattern on oral glucose tolerance test is very important because this can be a clue for diagnosis. Glucokinase is mild elevation, usually less than 4.4, but in previous reference, usually less than 3 millimole per liter increment on oral glucose tolerance test, but in the transcription factor, usually more than 4.4. The microvascular complication is not presented in glucokinase, but it is frequent in transcription factor MODY. The macrovascular complication is the same as normal in glucokinase, but frequent in MODY. HNF 1 alpha raised cardiovascular risk. Extrapancreatic manifestation 1 alpha usually presented by low renal glucose threshold with raised HDL cholesterol. What about the pregnancy? Glucokinase fetal inheritance lead to a macrosomic increase in body weight, about macrosomic decrease in birth weight, decrease in the birth weight lead to. So glucokinase, the fetal weight will be low, decrease, but in 4 alpha hypoglycemia with macrosomy, 1 alpha no fetal effect on the birth weight. How to treat for glucokinase? No treatment required except if coexisted with type 1 or type 2. With type 1 require treatment by insulin. If coexists with type 2 in this situation, and this is a very rare condition, require treatment as type 2. But the transcription factor sensitive to sulfonylurea and may progress to require insulin therapy. And so in exams they will ask about the question how to differentiate between different types and how to manage it. And also this is another table from international textbook, DeFronzo textbook. How to differentiate between type 1, young onset type 2, glucokinase MODY, and transcription factor MODY. So in insulin dependent, type 1 require insulin from the start except in the honeymoon. Type 2 glucokinase transcription factor MODY not require insulin therapy, usually require oral anti-diabetic medication, except glucokinase require no treatment. البيرنت for type 1 الريسك of type 1 diabetes is 2 to 4%, but for other types will be increased because all of them are modi autosomal dominant, so parents will be affected 80%. For type 2 parents will be affected in 60% because risk of inheritance is type 2 is more and more than type 1. The age of onset peak is 2 years too young for type 1. Adolescence for type 2 in young adults. Glucokinase from the birth but can be discovered at any age. Transcription factor at young age and adolescent. Those negligence, this is a manifestation of insulin resistance, so presented in type 2 in young adults, but in other forms is not presented except as a general population. The glycemic type 1 blood sugar usually elevated, very high. The young onset type 2 diabetes variable and progressive. Glucokinase is just mild stable. Is the transcription factor variable and progressive. The beta cell autoantibody will be positive in 80% of the patient at diagnosis and reach 90% in some cases. But for other types of diabetes, autoantibody is negative. So this table summarizes how to differentiate between type 1 and new onset type 2 diabetes in young adult, and the glucokinase and transcription factor. So I will go to another question from the tool book, and I want someone to read this question.
I'll read that. A neonate aged 6 weeks presented to the pediatric emergency with failure to thrive and dehydration. His blood test showed elevated blood glucose levels with low serum bicarbonate and elevated ketones, consistent with the diagnosis of DKA. Which one of the following genetic mutations is associated with the development of neonatal diabetes? I think it's E.
Yes, potassium beta cell, potassium ATP channel, which is KCNJ11. This is a channel mutation in neonatal diabetes which treated by glibenclamide. So an anti-islet cell antibody, if it is positive, this is a feature for type 1 or autoimmune diabetes. 1 alpha, this is for MODY. Insulin promoter factor IPF1, this is also for a rare type of MODY. So neonatal diabetes is presented by a genetic mutation in potassium beta cell potassium ATPase channel. So neonatal diabetes is a diabetes diagnosed up to 6 months of the age, and this is a monogenic diabetes. This is affect 1 in 100,000 live bears. Neonatal diabetes may be transmitted by autosomal dominant or autosomal recessive inheritance. We have two types. We have two common types of neonatal diabetes: a transient neonatal diabetes, which will disappear within 1 year of the diagnosis, but actually most cases will be recurred later on as type 1 diabetes. And another one which is permanent neonatal diabetes, the diabetes will continue after 1 year of life. And one of the most important gene mutation in the permanent neonatal diabetes mellitus is KER6.2, which is gene encode sulfonylurea receptor. So patient with KCNJ11 and ABCC8 mutation will respond to high dosage of sulfonylurea, glibenclamide, in a very high dose, not 5 milligram like adults. It usually requires 20 to 40 milligram glibenclamide to be responded for this neonate.
يعني control dose dependent, not weight dependent.
Yeah, actually in the protocol they give it according to the weight, but usually the dosage will be a very high dose of sulfonylurea. Oh, and actually glibenclamide, the most sulfonylurea used for management of neonatal diabetes is glibenclamide, not other forms of sulfonylurea like gliclazide or glimepiride. Glibenclamide or glyburide in another terms. Glibenclamide, this is the same as glyburide. some countries mentioned it as a globuride, but another countries mentioned it as a glibenclamide. So this is the most studied drug for neonatal diabetes. So this is another very important question. If anyone want to read it.
Okay. 25-year-old man presented with a 2-month history of thirst and polyuria. He had many weight loss and his body mass index was 26. And
at this point, can we diagnose it as a diabetes if we have a high blood sugar? If we need to diagnose it as diabetes, is it type 1 or type 2 in this situation?
هو كده not obese يعني
with type 1, but history of 2 months duration of symptoms is not with type 1 actually. 2 months history of symptoms with type 2. So in this situation, some criteria of type 2 and some criteria for type 1, so we should suspect another forms of diabetes, which is MODY or some, for example, in some situation, 1.5 diabetes.
Okay.
So this may have another form of diabetes, not type 1 and not type 2. So I will go, he had a sensory neural deafness. Once you see sensory neural deafness, so we should suspect what?
Mitochondria.
Yes.
Yeah.
So there was a very strong family history of sensory neural deafness and type 2 diabetes. Urine analysis shows no ketone. Investigation plasma glucose 80 millimole per liter, which is very high. What is the most appropriate next step?
Or test for mitochondria.
Yes, test for mitochondrial diabetes. So this in this situation, I should go to test for mitochondrial diabetes. So mitochondrial diabetes has a similar prevalence to rarer form of MODY, and another important diagnosis not to miss, caused by mutation in mitochondrial DNA, which is inherited by maternal inheritance. And I will cover maternal inheritance in the next slide. Commonly associated with sensorineural deafness, and usually it is called MID, maternal inheritance diabetes and deafness, MIDD, maternal inheritance diabetes and deafness. So don't forget RCAD, renal cyst and diabetes, MID, which is maternally inherited diabetes and deafness, which is mitochondrial diabetes. The clinical features include myopathy, cardiomyopathy, macular retinal dystrophy, CNS disease, renal disease. Clinical phenotype can be variable within the same family due to the heteroplasmy variable distribution of the abnormal mitochondria. Clinical management should include cardiology assessment, audiology because there is a sensory neural deafness, and a clinical genetic advice in some specialized center. So mitochondrial diabetes or mitochondrial disease actually is inherited through only the mother. If the mother is affected, all of his children will be affected. If the father is affected, none of his children will be affected. So this is very important. So mitochondrial diseases at all inherited through the mother only. 100% of his children will be affected. But if the father is affected, none of his children will be affected. So, and this is actually from first aid for the USMIL step 1, 2022, the same. Mitochondrial inheritance is transmitted only through the mother. All offspring of the affected female may show sign of the disease, but there is a variable expression in the population or even within a family due to the heteroplasmy. Cause the mutation in the maternally DNA, example mitochondrial myopathy, and also mitochondrial diabetes here, and Leber hereditary optic neuropathy. Yes. Yes, Dr. Naima, as I mentioned, clinical feature include myopathy and cardiomyopathy and microretinal dystrophy. So this we should share with neurologist and the cardiologist and the ophthalmologist in the assessment of mitochondrial diabetes. This is a genetic causes of severe insulin resistance. This is more rarer than Ilmodi actually, characterized by young onset of severe insulin resistance. The patient presented by acanthosis nigricans, dyslipidemia, hypertension, hepatic steatosis, polycystic ovary syndrome. And in this situation, if diabetes is diagnosed, we should raise the suspicion of genetic cause. And actually, most of the patients require insulin therapy and insulin sensitizer. And if require insulin, mega doses of insulin required, for example, high concentrated insulin U500, not 100, because most of patients presented by severe insulin resistance require about 400 and 500 units per day. One of the most types of severe insulin resistance is lipodystrophies. And lipodystrophy, actually, we will cover it, inshallah, in the, another sessions, inshallah. And already we have Endocrine Society published important guidelines about lipodystrophy. So I will cover the guidelines published by the Endocrine Society later on, inshallah. But at least we need to know that lipodystrophy means abnormal fat distribution leads to insulin resistance. And actually, is a face one of the most prominent feature. There are a lot of types of lipodystrophy, absence of subcutaneous fat in the face like this, and in the some arm and in the legs, which may be mistaken as a Cushing syndrome. So a loss of the fat from the limbs and increases central and ectopic fat, and this is usually due to mutation of lamina and another mutation in B bar gamma. So lipodystrophy usually due to the insulin resistance, and usually due to caused by mutation in lamina gene and B bar gamma gene. So this is the most important to know. Another types of insulin resistance, which is insulin receptor mutation, causing severe insulin resistance and can be presented initially by fasting hypoglycemia and the growth defect and hyperandrogenism. And a classical presentation in diabetes clinic would be young onset polycystic ovary syndrome, acanthosis nigricans in a lean woman. So we should suspect insulin receptor mutation and with severe insulin resistance. This algorithm is important to know all types of beta cell monogenic diabetes, and actually this is from the International Textbook of Diabetes Mellitus, the front book. If we have clinical or suspicious of monogenic diabetes, the most common is MODY, the most subtypes is glucokinase and transcription factor MODY. Glucokinase usually presented by mild, stable hyperglycemia, diagnosed since birth, no significant complication. Transcription MODY, familial, young onset of diabetes, sensitive to sulfonylurea, susceptible to microvascular complications. In neonatal diabetes, we have two types: permanent neonatal diabetes, which is continuous, just resolved within 1 year of diagnosis. And in neonatal diabetes, this is a diabetes diagnosed before the age of 6 months. Diabetes with extrapancreatic feature are CAD, renal cyst, and diabetes which is modified or 1 beta. This is structural renal abnormality, renal cyst, exocrine pancreatic deficiency, genitourinary abnormality. MED, which is mitochondrial diabetes, maternal inherited diabetes, and deafness. This is neurosensory deafness, short stature, maternal diabetes, and deafness. So this is just summarize all types of MODY, neonatal diabetes, and mitochondrial diabetes, which is 4 types. And this is also the same table, the same data, renal cyst and diabetes, which is HNF1 beta renal cyst, short stature, hyperuricemia, hypermagnesemia, abnormal liver function test. And mitochondrial diabetes, which is maternal inheritance, neurosensory deafness, nephropathy, neuromuscular feature. But actually, I put this table to summarize Wolfram syndrome. Wolfram syndrome, which is Diamond syndrome. The gene defect is Wolfram syndrome gene 1, WFS1G. This is formed from diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. But actually, this disorders is not presented all at the same time. Usually, the patient presented by diabetes insipidus, then later on, after a few years, diagnosed by type 1 diabetes mellitus, later on diagnosed by optic atrophy, and later on diagnosed by deafness. So screening of this patient is very important. Wolfram syndrome or Diamond syndrome, diabetes insipidus, the patient usually presented by polyuria and of course polydipsia. Specific gravity is low, and urine osmolarity is very low and not responding to water deprivation test. After injection of desmopressin, the osmolarity will be increased because this is osmolarity will be increased in the cranial type and not increased or just minimal increased in the nephrogenic type. And we will cover it in the hypothalamus and pituitary chapter, inshallah. So also this is the table from the Oxford textbook, and also as I mentioned, Wolfram syndrome. This is autosomal recessive disorder, diagnosed childhood onset diabetes and optic atrophy, Diamond, cranial diabetes insipidus in 73%, diabetes mellitus diagnosed usually in the 6th year, optic atrophy usually diagnosed in 11 year, and sensorineural deafness usually diagnosed later on, bilateral. The mitochondrial diabetes, as I mentioned, maternal inheritance. And another one, which is Rogers syndrome. Rogers syndrome, this is autosomal recessive type, manifested by megaloblastic anemia. And ARCAD, which is modified, ARCAD, autosomal dominant, HNF1 beta, and another one, which is DBED syndrome, which is autosomal dominant disease, diabetes and pancreatic exocrine function disorder. And actually, I extract this table from a very important guidelines, ISPAD guideline for management of diabetes in children, adolescents, diabetes. And actually, this is the latest guideline published in 2018. And within the next few weeks, they will update these guidelines to be 2022. And inshallah, I will cover it later on. This is a very huge guidelines for management of diabetes in pediatrics and adolescent age. Mehawish, I think just if you revision, we have some of the slides just to revision and solving some question. And I think we have an hour, inshallah. So this is just a summary for different types of moody diabetes. So I will go to this question from the toolbook. 24-year-old woman diagnosed as having type 1 diabetes since 8 years. She was noted to have elevated fasting blood glucose. Once you see fasting blood glucose, you must put in your mind what? Glucokinase moody. While undergoing treatment for urinary tract infection, she had been on basal bolus insulin with a total insulin requirement of 10 to 20 units per day. So it is diagnosed as type 1 with mild fasting blood glucose, elevated fasting blood glucose, and total daily dosage of insulin is 10 to 12 units per day. Body glycemic control, hemoglobin A1C is well, body mass index is not obese, no evidence of diabetic retinopathy, peripheral neuropathy. Which of the following criteria feature should raise the clinical suspicion of moody in this patient? Which one?
Absence of microvascular complications.
Absence of microvascular complication. Actually, the patient is just diagnosed since 8 years. 8 years. And so microvascular complications not usually presented in type 1 except mostly after 10 years.
No,
microvascular complication after 5 years.
No insulin dominance.
complications of type 1.
اعتقد دي.
What about the good glycemic control?
No insulin. No insulin.
Good glycemic control, if any patient have a good physician, he may good control his hyperglycemia. So it is not a criteria for any type of diabetes actually. What about so the good this is a type 1 diabetes actually. They mentioned that this is a type 1 and require just 10 units of insulin per day. So this is a not ideal dosage of insulin for any patient with type 1 diabetes in a 24-year-old male. So a low insulin dosage in this situation with a good control with this low dosage of insulin should suspicious of MODY diabetes. So this is the most important, that in MODY diabetes we should suspect it if the patient require a low dose of insulin. Genetic testing.
Excuse me, doctor.
Does it mean to refer it to sulfonylurea?
Or we stop the treatment?
Yes, we can stop it. Actually, we can stop it and diagnose it. Is it any type of MODY glucokinase or but actually don't stop insulin. Actually, if you suspect a MODY, go to the genetic testing before stopping of insulin therapy. Because in some cases of if you stop insulin therapy and the patient is already type 1 diabetes, he will enter in diabetic ketoacidosis, which is may be fatal. So don't stop insulin in this case scenario. I suspect it is MODY. In this situation, I go to genetic testing, and after a pair of the results of the genetic testing, I can stop insulin without fear of complications.
Thank you.
So genetic testing is important in different types, and actually this is the website for genetic testing of different types of gene, and we can go to it. This is a website. If you suspect of genetic testing, go to this website, and actually for example in the neonatal diabetes, they will receive the sample and do genetic testing free, not without any money actually. But they require some of the criteria to be obtain this testing. The patient should be less than 1 year and not be treated by a specific protocol and so on. So they can receive, anyone can follow this website and go to it. Another one which is MODY probability calculator, and I will go to this calculator. This is just a website. I will go to it. This is the website for MODY probability calculator. Is it not only for UK? Actually, I go to this website since a few years and available for anyone. But if anyone in the UK, it is more easy and more easy. But other than UK, I think they will accept by some of the criteria. Not anyone diagnosed by neonatal diabetes, they accept it. So this is a MODY probability calculator. You will answer some of the questions, and inshallah I will show this. If age diagnosed by year, for example, I will diagnose one by age 10. This is a male currently treated with insulin or tablet. I will ask no, not treated. Time of insulin to insulin treatment, if currently treated, I will show not currently treated with insulin. The body mass index, I will choose, for example, 27 kilogram. Hemoglobin A1C, I will put, for example, it is 7 in this situation. The current age, actually, I will put it is 12, and the patient is diagnosed since 2 years and not received insulin, so you must suspect it is glucokinase. Actually, parent affected with diabetes, I will answer yes. SNSTY, and I will calculate. So I think it is will be MODY diabetes. He mentioned that it is 75.5%. It is a MODY. And you can go to diagnostic testing for MODY, for example, here, and you can follow this how to MODY, and they will go to the testing, and each test what is the sample is required. And he mentioned that they need venous blood in plastic edit tube and so on. And where can I find more technical information? What are the test limitation and so on? You can follow this website, Diabetes Gene, and you can have a lot of and also if you need a neonatal diabetes, this is a genetic testing for neonatal diabetes. I will go to it. In neonatal diabetes, genetic testing is indicated for patient diagnosed with diabetes before the age of 9 of age, regardless of their current age. Genetic testing is condition the cost of genetic for non-NH patient who are able to pay is 120.50 sterling. Who are able to pay. So I think this is an optional. Parenteral sample testing, they need a parenteral sample and they ask a sample 3 to 5 ml of blood of preferred option and think to 10 micrograms, and they will give you the address and so on. So I think it is available for anyone. Using this test are currently able to find diagnostic criteria for 82%. So this is a very important website and everyone can go to it and search for it. Genetic risk score, this is another risk score for complex disease, and actually this is actually a repeated tools, and so I will have some of question. This is a 41-year-old lady, 4 months history of lethargy, increased stress, deny any weight loss. The body mass index is 25, waist circumference is 33.4. The fasting blood sugar is elevated. The random blood sugar is mildly elevated than the fasting, so this is a mild increase of the random, but actually for a glucokinase, 2-hour post-oral glucose tolerance test, not a random. But don't forget that the LDL is elevated, the TSH is normal, the gut antibody is positive. Which of the following is the correct diagnosis? Is it MODY?
LADA.
Yes, not MODY, because the gut antibody is positive. This is a type 1 or latent autoimmune diabetes of adults. So this is a type 1 or LADA. But actually not type 1 because the patient is already manifested symptomatized since 5 months. And actually type 1 diabetes is, cannot be stable for 5 months after symptoms. He will enter in decay. So in this situation, it will be latent autoimmune diabetes of adults. So this is I will rapid revision for LADA, and I can cover it inshallah in the next presentation. This is LADA, and I will cover it in the next session inshallah. In LADA, this is just slowly progressive type 1 diabetes. This is have some feature of type 2 and some feature of type 1. Some feature of type 1 like autoimmunity. Some feature of type 2 like insulin resistance and obesity. So the patient presented by, if you have a patient with islet cell autoantibody with insulin resistance, feature of insulin resistance, I must suspect LADA. And this is actually from important paper about LADA, how to the criteria for type 1 and the criteria for type 2 and autoantibody, and I will cover it inshallah in the next session inshallah. So LADA usually diagnosed after the age of 30 years. The patient rarely acute onset, autoimmunity is increased, ketosis is rare, the beta cell function usually decreased, usually insulin dependence within 6 months, even years after the onset. The body mass index usually not overweight. The risk of metabolic syndrome increased, normal to overweight الweight. The HALA susceptibility will be increased. And another one is ketose prone diabetes. I will cover it in the next session inshallah. So I will go to some of the questions, and inshallah I will repeat the last topics inshallah in this next session. But I want to give these questions. This is a 40 year. Yes.
Please, I have a difficult case and cannot differentiate the patient type 1 or LADA. Boy, 17 years old. Okay, come to
17.
Yes.
So in 17, as we mentioned, 17-year-old not LADA, because most of LADA usually is more than 30 years. This is age at diagnosis.
Okay, Dr. Khaled. Now the patient undiagnosed type 1 and other type diabetes mellitus come to my clinic, blood sugar around 400. Okay.
Yes.
The patient obese, BMI about 33. Okay. I request the antibody, anti-GAD, the normal up to 16. The patient 25, and the C-peptide within normal too.
25, so it is a positive GAD, yes?
Yes, positive antibody. Does the patient have insulin resistance, and the patient gave history previous months, lost 10 kilogram, and polyuria and polydipsia, the symptoms like type 1. So the patient diagnosed type 1 or
type 1
brown diabetes, and
no, this is actually the type 1. Why type 1? اللي autoimmune antibody is positive. This is one. Severe weight loss is with type 1. Why the patient is obese? Because obesity is prevalent in general population. So obesity per se is not a diagnostic for type 2. In obesity, we have a lot of obese patients. We have a lot of obese patients in general population. So the prevalence of obesity in type 1 is the same as the prevalence of obesity in general population. Obesity is not a diagnostic for type 2, but it may suggestive for type 2 if there is a strong family history, if there is a manifestation of insulin resistance with negative autoantibody. Positive autoantibody means two types, type 1 versus LADA.
Dr. Khaled, the patient now severe insulin resistance, have a cancerous ligaments in the neck and under axilla.
This is a manifestation of insulin resistance. So insulin resistance may be presented in type 1, actually in the obese type 1. Type 2 is not insulin resistance alone. Insulin resistance, obesity, and genetic factor, inheritance.
Dr. Khalid, the plan of management.
Insulin therapy. This is a type 1, so basal bolus insulin therapy. And actually, we can give metformin in obese type 1 because the guidelines recommend the metformin can be prescribed for type 1. No, not we prescribe metformin because we suspect it is a type 2. This is a classical picture for type 1.
Dr. Khalid, another note, when the patient come to my clinic, because dehydrating the patient, I requested VBG, okay? pH normal, 7.25, but the biocarb low, and the
low what? Low to how extent? Because diagnostic criteria for DKA, pH less than 7.3 and bicarb is less than 15. And in some literature, bicarb less than 18. So what is the value of bicarb? We cannot actually. If you need to diagnose the DKA, we have 3 criteria: pH less than 7.3, bicarb less than 15, and another one, blood sugar is more than 20 or 200 or 250. Another one is ketonemia. One criteria is not diagnostic for DKE. Okay, so go on, Dr. Alia. Dr. Alia. Yes, bicarb. What is the value of bicarb?
نعم دكتور خالد.
What is the value of bicarb? Bicarb level here.
Bicarb is low. The patient 15. And the hypokalemia, the patient potassium 3.
It may be, of course, it may be impending DKA. It may be initial phase of DKA. It denotes insulin deficiency. Not complete, but it may be incomplete insulin deficiency due to a low dosage of insulin usage and with severe infection or severe stress. So DKA, any patient, and actually we will cover DKA in a separate session, inshallah, because it is a very important in the exam and the clinical practice.
Dr. Khaled, C-peptide positive in type 1. This patient has positive.
Actually, C-peptide, I will cover C-peptide in more details in the next session, inshallah. C-peptide and autoimmune antibody, because this is a very important items. Actually, I will cover it in more details. But actually, C-peptide can be positive in some case of type 1, especially in initial phase. But after 1 year of diagnosis of type 1, C-peptide must be negative. Can lipodystrophy present in type 2 over 50 years of age? Yes, can be presented. There are a lot of lipodystrophy actually. If you not, Dr. Ashraf, if you are sure, if you are not sure if the patient is type 1 or type 2, please give insulin. If we not cannot diagnose is it type 1 or type 2, please deal with it as type 1 and check for antibody. And after reviewing of the antibody, please redefine your diagnosis. If antibody is positive, so this is a type 1. If negative, so it is a type 2, and you can stop insulin and give oral antidiabetic medication. But any case presented by severe hyperglycemia, I must start by insulin therapy. If any patient presented by severe weight loss, like this patient, Dr. Ala, I must start by
metabolic.
Yes, the patient weight loss about 10 kilograms.
So LADA, don't forget that LADA usually presented in a patient with more than 30 years of age. Latent autoimmune diabetes of adults, not children.
Weight loss because of high sugar?
Yes, weight loss because this is a type 1 diabetes.
Yes.
Dr. Khalid, the patient antibody might elevated when I suspect the type 1.
Actually, I will cover autoantibody because the autoantibody is different types. I can give you just a hint because this is one. Inshallah, I remove it. Actually, I can. It is in this session, but actually, I remove it from this session because it to save some time. This is from the next session. Actually, this is the autoantibody. The autoantibody in type 1, there are a lot of autoantibody. Most of them, some of them are more specific and some of them are less specific. And when more than one autoantibody is present, this I will cover it inshallah in the next session. So I did not want to lose the time today. So I want to go to some of questions. Question, but if anyone has a question, it is welcome. Yes, lipodystrophy can be presented in a patient in type 2 over 50 years of age. Usually in clinics, oral anti-hyperglycemic are being started with high blood glucose and high hemoglobin without genetic testing. Then what to do? If you suspect it is a MODY, in this situation, I will go to genetic testing according to probability. If we cannot do genetic testing, in this situation, is C-peptide, and this is for MODY, Dr. Chavan, or type 1 versus type 2. Type 1 versus type 2, it is easy. It is just autoimmune antibody, C-peptide. It is can be diagnostic. But MODY diagnoses genetic testing. If severe elevated blood sugar, I must start by insulin or sulfonylurea if I suspect MODY and the patient is well controlled on it. And I will not stop this medication except after genetic testing. This is a 40-year-old man presented with, yes, symptom of polyuria, polydipsia, previous 6 weeks, strong history of diabetes, body mass index is 24, dark hyperpigmented skin armpit. This is the same as your case, Dr. Ali. Random blood sugar is elevated, the pH as your case is elevated, and the venous bicarb is normal. Urine sugar plus 2 keto negative. Which one of the following clinical biochemical feature will support the diagnosis of type 2 diabetes over the diagnosis of monogenic diabetes? Which one?
Acanthosis nigricans.
Acanthosis nigricans.
Wrong family history.
Strong family history of diabetes.
Strong family history is a strong family history. Clinical will support diagnosis type 2. what is the more common inherited, type 2 or monogenic diabetes? Which is more inherited?
Monogenic.
Monogenic is autosomal dominant, so the risk is 50%. What about the type 2? Risk of inheritance what? Type 2. 25. 25. If the father is type 2 diabetes, the risk to inherit this to his children is 25.
في acanthosis nigricans.
So the right answer is acanthosis nigricans. The presence of acanthosis nigricans is a pathognomic for insulin resistance.
For insulin resistance, yes.
And also maybe for gastric cancer and some of malignant tumors. So in general condition, it is a symptom for insulin resistance, and this is the acanthosis nigricans in the neck. And another question, 29-year-old.
Okay.
Dr. Khaled, why not a strong family history? معلش again.
Because monogenic diabetes is inherited as autosomal dominant.
So 50%.
Yes.
So 50% will inherit. So a strong family history is with monogenic diabetes more than type 2 actually. Type 2 runs in families, and inheritance is about 25%, and not 50% like monogenic diabetes. And actually, monogenic diabetes is, I speak about MODI because monogenic diabetes, another type of monogenic diabetes is neonatal diabetes, which is autosomal dominant and autosomal recessive sometimes. But autosomal dominant for MODI diabetes, which is one most common type of monogenic diabetes. Another question, 29-year-old woman referred to the clinic by gestational diabetes, which is diabetes diagnosed during pregnancy and also in the previous pregnancy. There is a family history of type 2, body mass index 23, oral glucose tolerance test carried in the first trimester showed fasting is 5.8, 2 hour is 8.9. And actually, to diagnose gestational diabetes, we just require fasting and 2 hours with 75 gram oral anhydrous glucose. In her previous pregnancy, she had started treated by basal insulin and control her fasting hyperglycemia. Once you use this feature, what type of MODI you must suspect? Fasting, mild fasting hyperglycemia, just mild increment of blood sugar from fasting to 2 hours. Insulin.
Glucokinase, yes.
Yes, glucokinase. This is monogenic diabetes glucokinase. Yes. She had not required insulin during the postpartum period. Which of the following is most likely diagnosis based on her clinical profile? Of course, this is a monogenic diabetes. Why not GDM? Actually, it may be GDM, but mostly it is a MODI, glucokinase MODI. Why not LADA? Why not LADA?
Diagnosed at the first trimester.
Yes. The first trimester, GDM usually diagnosed in
24 weeks.
After 20
second half of the pregnancy. Usually diagnosed in the second half of the pregnancy.
But I think gestational diabetic in British different than American.
Yes, actually numbers is different because in the British they diagnose it according to the fasting and 2 hours only after 75 gram. And actually gestational diabetes, any hyperglycemia diagnosed during pregnancy must be labeled as gestational diabetes. But a true gestational diabetes is a hyperglycemia diagnosed in the second half of the pregnancy. And we will cover it later on, inshallah. So this is usually a glucokinase MODI. This is presented by persistent mild fasting hyperglycemia, a small increment after 2 hours during oral glucose tolerance test. Fasting glucose intolerance diagnosed in the first trimester. Usually the patient is slim, not obese like type 2. Previous insulin treatment during pregnancy and after pregnancy not required treatment. History of GDM with fasting, hyperglycemia, and type 2 diabetes in the first degree relative. This is usually suggestive of glucokinase. And actually, this is, we will cover it several times in previous, and inshallah in the next sessions I will review it again. So
question, the second 2 hour increment not high.
Is mild elevation. Actually, a 2 hour just in this one. Glucokinase usually a 2 hour post oral glucose. Actually, the diagnosis of GDM.
Pregnancy different than normal person.
One abnormal. The diagnostic criteria, one abnormal value is sufficient. And the diagnosis of diabetes during gestational diabetes is fasting more than 100, which is 6 point, actually 5.6.
5.3.
5.6.
Dr. Khaled, what is the treatment for such a case?
The patient usually during the pregnancy, the most important is treated by insulin in this situation.
Although we can start for this patient glimepiride, or this
glimepiride is approved during the pregnancy, actually after the first trimester, and can be treated. Actually, gestational diabetes is according to the British guidelines or NICE guidelines. Usually, any hyperglycemia diagnosed during pregnancy, according to the NICE, should be managed primary by lifestyle modification and diet for 1 week. If not improved to the targets of blood sugar, we should start metformin. If not controlled, we should start by insulin. But if the patient refuses insulin, we should start by glibenclamide. Except if in fasting blood sugar more than 7 or there is a macrosomia, in this situation, we should start immediately by insulin. But actually, in this scenario, this is a mode diabetes, glucokinase mode diabetes, which need to be treated by insulin therapy during the pregnancy. Glibenclamide can be treated initially, but in most cases, in the last trimester, as mentioned in the Oxford handbook, usually require to transfer to insulin to avoid the passage of glibenclamide to placenta, which can cause fetal hypoglycemia.
Okay. Do you think metformin is good for this patient with this body weight?
Metformin?
Yes.
Actually, a nice recommendation, manage gestational diabetes at any stage by metformin as a first choice, except if fasting blood sugar more than 7 or macrosomia at any body weight. But actually, the evidence of metformin is more effective in obese patients.
Okay.
So even in type 1 diabetes, metformin is approved only for the obese. What?
I think also the idea behind using metformin during pregnancy, because the insulin resistance is exerted by the placenta and the placental hormones.
Yes, yes. And actually, we will cover it, inshallah, later on. And Dr. Shaban asked, any preventive measures for insulin resistance suspected cases? Yes, lifestyle modification, weight loss. The most important management of insulin resistance is weight loss. And also metformin and pioglitazone can be prescribed and may be off-label use. Fasting here is low, after 2 hours is high, but actually, Dr. Asma, the diagnostic criteria for during the pregnancy, fasting more than 5.6 is a cutoff point for diagnosis of diabetes during the pregnancy, not 7 like a non-pregnant female. And after 2 hours, it is 7.8, which is equivalent to 140 milligram per deciliter. This is a cutoff point for diagnosis of diabetes during the pregnancy, according to the NICE, and actually according to another protocol. And Dr. Shaban asked about how to differentiate between clinically between GDM and monogenic diabetes, and actually I will cover GDM in more details in separate sessions, inshallah. So this is algorithm extracted from this important book about diabetes associated with single gene defect and the chromosomal anomalies published by Karger. So if we suspect a monogenic diabetes, we should go to islet cell autoantibody if it is positive, so it is a type 1. If the patient is obese with insulin resistance feature, I must suspect it may be type 2. If there is a severe insulin resistance, lipodystrophy, I will go to lipodystrophy. If no, with a family history, autosomal dominant pattern, usually 3 generation, I should suspect MODY subtypes. If mild stable fasting hyperglycemia, this is a GCK, no treatment required, diet only. Insulin is required like our previous case in pregnancy, depending on fetal growth. If severe or progressive hyperglycemia in adolescents or young adults, this is HNF 1 alpha, more frequent, or 4 alpha mutation. Doing oral glucose tolerance test, large increment, frequent complications, and we treated by low dose of sulfonylurea. Second choice will be metformin or DB4 inhibitor. If early onset of diabetes, this is a neonatal diabetes, and the most common is ABCC8 or KCNG11 mutation, and the patient usually responded to sulfonylurea treatment, glibenclamide. Atypical types like renal cyst and diabetes with renal hypoplasia or pancreas, which is HNF1 beta mutation, treated by insulin therapy from the diagnosis. And lastly, specific MODY types, very rare types, which is WFS1, which is Diamond syndrome, and another one which is ENS BDX cell neuro D1, usually require insulin therapy. So I just have this is the last session, and I just have some summary and some questions. So this is the most important slide in my presentation today. This is how to differentiate diagnosed diabetes according to the WHO, which is the most important for the exam. And also I gave the American Diabetes Association recommendation and numbers for diabetes and pre-diabetes, and also impaired fasting and impaired glucose tolerance test according to the WHO. Another one, the limitation of hemoglobin A1C is not appropriate for steroid or antipsychotic patient, acute pancreatitis during pregnancy, for type 1, for young adults, children, hemoglobinopathy, short duration of osmotic symptoms, hemoglobin A1C will give false negative, may give false negative results. And another important table about the clinical diagnosis of the diabetes between autoimmune diabetes type 2 and gestational diabetes and specific types. Don't forget that Cushing, acromegaly, pheochromocytoma can cause diabetes, and also some drugs like corticosteroid, diazoxide, thiazide, antipsychotic, atypical antipsychotic, and some of its checkpoint inhibitor can cause diabetes. And so don't forget that some syndromes may be associated with diabetes like Down, Turner, Werner, and Alstrom syndrome. And this algorithm, how to investigate of a new diabetes diagnosed before the age of 30, according to the Oxford handbook and Oxford textbook. And this is a very important algorithm to revise. And genetics is the second most important slide in my presentation today. If the mother have type 1, the risk of inheritance is 1 to 2%. If the father has type 1 diabetes, the risk is 3 to 6. If both father and mother have type 1 diabetes, the risk will be 25 to 40%, but in the Williams presented as 10%. The concordance rate in monozygomatic twins is 50% for type 1, but it is 60 to 100% for type 2. The risk, if the mother or father has type 2 diabetes, the risk is 25. But if the mother and father have type 2, the risk will be 30 to 80%. And actually this table, how to differentiate between glucokinase and transcription factor, is very important, and I covered it several times previously. And also how to differentiate between type 1 and young onset type 2 diabetes, which is more common nowadays because the prevalence of obesity is very common nowadays, and the glucokinase and the transcription factor MODY, how to differentiate these 4 types of diabetes, which may have a similar clinical presentation and similar age of presentation, is very important. Another very important slide in my presentation today, which is extracted from the Atoll book, the second edition, also the same table presented in the first edition, how to differentiate between different types of MODY, which is the most important slide in my presentation today. And this is another slide, important slide. Don't forget that Wolfram syndrome, which is autosomal recessive disorder, which is Diamond syndrome, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. And this disorders is not presented at the same time. And this is some criteria for LADA, latent autoimmune diabetes of adults, and I will cover it inshallah in the next session. So at the end, I will want to finish by some of the questions from the different questions bank. I think it is, so this is a 17-year-old male student present with a 3-week history of serous polyuria, polonitis, and weight loss. What is the most appropriate next investigation? Fructosamine, hemoglobin A1C, random blood sugar, urine ketone, 75 gram glucose tolerance test. What is the most appropriate investigation?
Urinary ketones.
Random blood glucose.
Yes. Random blood glucose.
Random blood glucose.
Yes, in this situation, random blood sugar is the best one. Not required for 75 gram glucose tolerance test or fructosamine or hemoglobin A1C or urine ketone. Just do random blood glucose. What is the cutoff point for random blood glucose for diagnosis of diabetes?
11.1.
11.1 millimole per mole per liter.
200 milligram per
200.
Yes, 200 milligram per deciliter. So this is a cutoff point.
If this question right fasting blood sugar, we choose random also?
What?
If in this fasting blood glucose, we choose also random?
Random. What is easily accessible? Random or fasting blood sugar?
Random.
The patient is available to us to do random at any time, but fasting blood sugar requires the patient is fasting in the next day. So in this situation, random is more accessible, and this is the best next step. And actually in the exam, they ask about the most appropriate next step. Actually, hemoglobin A1C is a right answer. 75 gram glucose tolerance test is right answer. Fasting blood sugar is right answer. But what is the most right answer in this scenario is random blood glucose. And in another question is a 25-year-old man incidentally detected have elevated fasting and postprandial blood sugar, have a renal cyst. Once you see renal cyst, strong family history of diabetes, body mass index what type?
1 beta.
One
Yes, 1 beta, which is modified. So once you renal cyst in a strong family history of diabetes, young patient, body mass index, this is a HNF 1 beta.
Okay.
And this is a patient diagnosed by type 2 diabetes. Hemoglobin A1C is 51.9 millimole per mole, which is normal less than 48. What is the lifetime risk of this lady twin sister having type 2 diabetes or any abnormality for glucose metabolism?
70%.
Yes, 70%. So 70%. So in a case of monozygotic twins, risk is about 45 to 95%. So in some another situation, it is 60 to 100%. Another question, 90-year-old man lost 2 kilograms in weight, presented diagnosed diabetes since 1.5 years, body mass index 33, so it is obese, random blood glucose is 18 millimole per liter, and his hemoglobin A1C is 56. He has taken gliclazide and metformin, and father and the grandfather had developed diabetes. So there is a very strong family history in 2 generations during their 20s. So we should suspect
Moody.
Hemoglobin A1C is serum C peptide is normal. The antibody is negative. What is the likely diagnosis?
Moody.
مودي ولا لا؟ مودي ولا لا؟
لا مودي.
مودي because اللادا
after 35
over the age of 30.
and اللادا الاوتو antibody must be positive.
في مهم شيء بعيد كده.
Very important. So اللادا must be الantibody is positive and the age usually more than 30 years of age. So this is Moody. What is the concordance rate of developing type 2 diabetes in monozygotic twins?
60 to 100%. 60 to 100%.
60 to 100%. So this is most important. And this is a question from the on examination 2022. A patient, male patient, 52 year, dyslipidemia, hypertensive, attend a surgery for 75 gram oral glucose test. The body mass index 29. Blood pressure is okay. Amlodipine perindoprel is 0 point, which is fasting 5.9. 2 hour is 10.4. Which of the following is the correct interpretation of this result?
Impaired
glucose tolerance.
Impaired glucose or impaired fasting? Fasting, is it normal or not?
Fasting is normal.
بالنسبة ل WHO يبقى normal.
Yes, this is the most important. So fasting blood sugar is normal according to the WHO and NICE, but it is abnormal according to the American recommendation. What about the 2 hour?
2 hour is light.
Is impaired. So in this situation, this is impaired glucose tolerance test. If we have impaired fasting and impaired 2 hour, in this situation, we can call it as
pre-diabetic.
Or pre-diabetes. This is American term. Actually, it is American term. But what about according to the WHO? Impaired fasting and impaired 2 hour. In this situation, it is
2 diabetes. Diabetes.
It is no. It is impaired glucose tolerance test. So if there is impaired for fasting and impaired glucose tolerance test, this is only impaired glucose tolerance test, not impaired fasting and impaired glucose tolerance test.
Okay.
And actually, this is from the Oxford textbook. This is, I mentioned it previously. The cutoff points for impaired fasting and impaired fasting and 2 hour and random blood glucose and units for diagnosis of diabetes. This is another one. This is a 40-year-old school teacher presented with a medical assessment, 2 months history of osmotic symptom, elevated glucose. There is no family history. Body mass index is normal, 22. Random blood sugar is elevated. The pH is normal. Bicarb is normal. Urine ketone negative. Which one of the following tests may be useful in establishing the underlying diagnosis, considering her clinical profile? Antigen, mitochondrial gene mutation, oral glucose tolerance test, serum ferritin and iron binding capacity, toxicology.
The anti-GAD
maybe leather?
Anti-GAD.
Yes, yes. So this scenario, this is a typical manifestation of the LADA. So I need to do anti-GAD antibody. If it is positive, this is a LADA. If not positive, so I will diagnose it as type 2.
Dr. Khaled, why we not choose oral glucose tolerance test?
What is the value of oral glucose tolerance test? It is just a diagnostic for diabetes. We sure he is a diabetes. He has osmotic symptom and elevated random blood sugar, so he is a diabetic. Oral glucose tolerance test, the main value of oral glucose tolerance test is diagnosis of diabetes, not a diagnosis of different types of diabetes. In a case of glucokinase, this is just notes about elevation of oral glucose tolerance test after 2 hours. Not diagnosed actually, but if it is present, so it is subjective glucokinase mood.
Okay.
Which of the following is the correct lifetime risk of type 2 diabetes for the lady daughter? She has a type 2 diabetes treated by diet and exercise. The body mass index is obese, and she has a 13-year-old daughter and is concerned about the potential risk of her daughter subsequent developing type 2 diabetes. So the mother has diabetes and ask about the lifetime risk of type 2 diabetes for his daughter.
25% يعني
1 in 3.
Why Dr. Ashraf 1 in 14? 1 in 14 it represents, this is type 2 not type 1, Dr. Ashraf. This is a type 2.
25% المفروض يعني
1 in 3. 1 in
That
3.
will be closer 1 to 3.
كل 100 25
1 to 3 is equivalent to 30%. But actually here in the study behind this is an important source. They answer it as 1 in 7. And mention that diabetes risk in sibling and offspring of patient with type 2 diabetes is approximately 15%, not 25% like at all, but I am with 25% actually. And here this is inshallah in the next session, inshallah, what is the probability of her developing type 1 diabetes in the next 10 years on incidental detection of this 3 antibody. If the 3 autoantibody glutamic acid decarboxylase, which is GAD 65, insulin autoantibody and IA2A, this is 3 antibody is positive. What is the risk probability for development of type 1 diabetes in the next 10 years? What did you say?
20 to 25%.
22? Actually, if you have 3 autoantibody pathogenomic for type 1 diabetes, the risk will be more than 80%. So in some countries, they will screen for this autoantibody, but what is the next? Type 1 diabetes up till now is not a preventable disease. So global screening for this autoantibody is just for researches only, because this is not a preventable disease. But for type 2 diabetes, because type 2 diabetes is a preventable disease, we have a lot of scores that can screen for type 2 diabetes in a specific population. For example, find risk score. And in the American guidelines, you will find they mention a find risk score that screen for probability for development of type 2 diabetes in the next 5 to 10 years, and you can prevent type 2 diabetes. So screening is very important in a preventable disease. For type 1 diabetes, screening has no value. So this is the autoantibody, and I will cover actually in the next session, inshallah, because this is the topic of next session, autoantibody. Yes?
I wanted to ask.
Yes, Dr. Ashraf.
If we have a child 7 or 8 years and...
voice is not clear enough, Dr. Ashraf. Please raise your voice.
Just if you have a child 7 years old and you are quite sure that he is type 1, do you still need to do autoantibodies?
No. Autoantibody required only if you have a debating diagnosis, except if you want to document this. And actually, in clinical practice, an autoantibody is not required except in very, very minimal situations. If you're not sure he is type 1 or type 2, in this situation, I will do autoantibody or C-peptide. But if we diagnose he is a type 1, no need for autoantibody. If we diagnose type 2, no need for autoantibody. And also, serial C-peptide has no value in any condition, because in some situations in our clinical private, we see a lot of physicians order serial C-peptide for type 1, for sure, 100% type 1 diabetes.
Thank you.
Doctor, regarding the previous case, the prevalence was 1 in 7. I don't get it.
This one?
Yes.
This is actually the answer, and this is the explanation from the study BRN. They mentioned that risk for development of type 2 diabetes in the offspring is 15%, and 15% equivalent to 1 to 7 in 7, 1 in 7. But according to the Atoll book, they mentioned that the risk for development of diabetes is 25%, which is equivalent to 1 to 4, 1 in 4. 1 in 4.
البرنامج هو خلاص بيخلص.
اوكي
انا خلاص على طول خلاص. Okay. So I think this is the last slide in my presentation today. So I label it, I add end to be sure this is the last one. So at the end of this sessions, if anyone has conflicting points, please send them through a WhatsApp group, and I will try to clarify them in the next presentation, inshallah. And also, if anyone has any remarks about this presentation and this course, how this course works, please let me know, and I can do what we need. So thanks for your all. Inshallah, today I will upload this session, inshallah, if I have time, because at 10 o'clock we have online presentation with, inshallah, to be published in the next Friday. Inshallah, in the next Friday, I will continue diabetes sessions, inshallah. So see you later, inshallah. Assalamu alaikum.